Good morning. A warm welcome to Online Anaesthesia, an anesthesia update in Zoom platform sponsored by Akurula and hosted by A1 Logics. And our media partner is Anaesthesia TV. The relationship between pain medicine and anesthesia lies in the shared goal of ensuring patients' comfort and minimizing pain during and after the medical procedures. That's why we have included pain update in our online anesthesia update. Today, we have two stalwarts of pain medicine, Dr.Gurumoorthi sir and Dr.Madhan Pandian sir in our platform to deliver lectures on epidural steroids and its current concept and nerve entrapment syndrome, what is new. This will be followed by our video demo by Splanchnic nerve neurolysis, how I do it, by our young pain physician, Dr. Vissnukumar. Today's session is moderated by our own colleague and pain physician, Dr.Rajesh Jeyaprakash of Madurai Meenakshi Mission Hospital. Over to you, sir.
Thank you, sir. Thank you, sir. Good morning. Good morning, one and all. So in this online anesthesia program, so this session is about what is happening in pain medicine, our update on pain medicine. So we have three extreme pain physicians who are full-time pain physicians here with us to deliver, to share their experiences. The first lecture is by Dr. Gurumoorthi, a good friend of mine. He is from Trichy. He's a senior consultant in Dr. Guru's Interventional Pain and Palliative Care. And he is going to talk about epidural steroids. What is the current concept? So it's a very important topic that even anesthesiologists or pain physicians, everyone does that epidural steroid day to day in their practice. So how to go ahead and what is the current concept related to that? So over to you, Guru. Please share your.
Thank you, sir. Thank you, Dr. Rajesh. So thank you, one and all, for joining on this session in the morning. So thank you, Online Anesthesia, for giving us the chance. So today, when we had a discussion which topic to go ahead, so me and Rajesh were discussing, and we thought, okay, let me go for a very common topic. Okay, so then we had zeroed on epidural steroid. Rajesh, as my slides are visible?
Yeah. You are readily visible.
Okay, fine. So we had zeroed on epidural steroid. This is a very simple topic, right? If you ask any pain physicians who are busy in practicing in pain management, if you ask what is the common procedure done by you in your pain clinic, especially in the spine, they will say it's epidural steroid, right? So you're not even pain physicians, most of the anesthesiologists, if you ask what is the procedure you do in pain medicine, then they may be saying in epidural steroid. This is very commonly done procedure. Even if you ask any of the pain physicians, okay, sir, can you tell me, so which procedure you are stuck very frequently? So again, the answer is epidural steroid. Okay, so though it's look like a simple procedure, we land up occasionally, it's not very frequent, but this is the one procedure where we stuck up. We have find difficulty in putting those procedures. There are a lot of debates whether it works or not. So then we thought of, okay, we had got young doctors in this forum. Okay, then we thought of, okay, let me talk on the most common things. So we had started with epidural steroid. So these are the content we are just going to have a discussion for the next 30 minutes. I am going to dedicate more time for discussion. Okay, so I expect those who are the participants to come up with the questions. Epidural steroid, nothing to discuss more as a presentation. Okay, so I will just try to wind up in 25 to 30 minutes. So whenever I start reading anesthesiology, so I never read history. Even when I'm in pain medicine, I never read history. So because when I did my MD, the curriculum don't have that much importance for history. We don't get any questions in history. But when I started presenting, okay, then when I started presenting on the forums, then I had to read something which I had never done. So one thing is the history. So when I read about epidural steroid, I just found this. So the first spinal puncture was done in 1985. The first injection for pain is done in 1901. Right? It was done by two people on different occasions, one by Sekara and Kathleen. So Sekara had got good results in that block, and Kathleen don't have any good results. So the answer is because Sekara did transfemoral and Kathleen did caudal. So Sekara used more volume and Kathleen used less volume. So Sekara has got good results and Kathleen don't have that much good results for sciatica. So it's not that thing. The thing is, it took almost 20 to 30 years for epidural steroid to the procedure started, because Sikard became a radiologist and Catherine became a surgeon. Okay, so they stopped doing the procedures in 1930. I think they started giving epidural steroids. This history I just wanted to insist because it's the line given there. Some innovations in the history of medicine spread quickly. For example, discovery of ether to anesthetic patient in 1846 spread across the Atlantic from Boston to Paris and London in only 4 weeks. For example, these things spread very fastly, but for example, the epidural steroid or epidural treatment with local anesthetic took very long time. So it's almost took 2 to 3 decades for other people to realize, okay, we can start doing off. So why I took up this slide is, it's happening nowadays also. So what we are doing, most of we anesthesiologists, we are part of not very, it's less numbers. We are getting trained in pain management. But when you come out, we turn our pathway again to anesthesia. So most of us are not coming to pain management. And even those who are practicing pain management, they have to struggle a lot to get their practice done, because it is not because of the skill, it's because of the knowledge present among even our colleagues. We can say that if you ask some anesthesiologists, do you do pain practice? They may come up with the answer, yes, I do. So then if you ask, what is the thing you do? They say, I do epidural steroids. Okay. Sometimes they will say, I used to give morphine and all. So just understand, just giving epidural steroid is not equal to running a pain clinic. Okay. So it needs more skill. It needs more knowledge. So that's the one thing we have to occur rather than from anesthesia. Just doing anesthesia, we can't get the skill of a pain management. Second thing is, though we say epidural steroid injection is very commonly done in pain clinic, we are doing, most of us, not I am talking about as a common, it's almost more than 90% of the epidural steroid done by anesthesiologists is done as a technical thing. So you will be getting a patient from an orthopedic or a neurosurgeon and they will ask, give epidural steroid, and you'll be just doing it. So if any one of you, can you answer? So what is the common cause for failure for epidural steroid? The answer is, you are giving this technique, you are giving the steroid in a wrong patient, because most of us don't know what was the diagnosis. Most of us will think it's radiculopathy. There are a number of causes which can cause back pain. Okay. So it's only the clinical examination which is going to help you. It is the diagnostic block which is going to confirm your back pain. We just go on giving epidural steroid. Just, for example, the patient is not responding for analgesic just with back pain. In a 60-year-old male, we just go on giving epidural steroids and the patient is not responding. Actually, the diagnosis may be facet joint and you are giving in a wrong patient. That's the most common cause for failure of epidural steroid. You are giving a steroid, you are not getting a response, you are just telling that, okay, the steroid has failed. No, you are failed because you are done in a wrong patient. This is the most common cause of failure in epidural steroid. So what is the indication? So we had got a lot of indications for epidural steroids. So if you go to the literatures, they will have a lot of case series, a lot of studies, but the most common indication is discogenic pain, radiculopathy, canal stenosis, and failed back surgery syndrome. These are the 4 important indications for epidural steroids. The most common thing will be radiculopathy because the results will be far better if you do it in radiculopathy. Other indications like coccydynia, proctalgia figus, acute herpes zoster, and chronic pelvic pain, and so on. So you can try, but you have to do it as a reserve procedure. You just cannot say, okay, I will try epidural steroid in this patient. Just you have to try everything. If everything fails up, then you can try with epidural steroid in these patients. What are the contraindications? As the anesthesiologist, we already know. So what are the contraindications? But still, we have to focus on very important thing which we always miss it. That is glaucoma and increased intracranial pressure. Okay. So this question you should always ask if you are going to epidural steroids. I think most of us don't ask this when we are going for anesthesiology, but this is a very important thing in epidural steroid. You have to ask the patient. What happens if you are not asking the question? If the patient has got angle closer glaucoma and you are just go on injecting, sometimes it can cause retinal hemorrhage. So if the patient has got increased intracranial pressure, if you just go on adding this 10 ml of epidural steroid, then they may be going for coning. So we should be very careful with these patients. There is a debate regarding antiplatelets. Okay, so most of the interventions, especially these epidural steroids, we use it we are least bothered about NSAIDs and aspirin, but still there are a lot of studies saying that okay, even you can do with clopidogrel, dabigatran, and everything you can do it off, but still for the safety of the patient, better stop it as recommended as we follow it for anesthesiology. But only thing you have to switch over with heparin. Okay, don't, if the patient is having a CVA and you are stopping antiplatelets, it's going to aggravate more. Better always put it on some antiplatelets. So, for example, the patient with CVA for the last less than 6 months, better put it on heparin and stop it off. Okay. So these are the methods as commonly we do. So we have got 4 regions: sacral, lumbar, thoracic, and cervical. So if you look at the sacral, there are 2 options we do. We can do transforaminal or we can do caudal. Okay. For example, if it is a lumbar region, we can do interlaminar, caudal, and transforaminal. In case of thoracic, we can do interlaminar and transforaminal. It's a really difficult thing to do it in thoracic. But in case of cervical, the option is interlaminar and transforaminal. These are the options available. I'll be going to tell what is the advantage of each techniques, why we prefer those techniques than other techniques. So let me start with next slide. So let me start with caudal epidural. I think this is the most commonly procedure done by an anesthesia pain physician, not by an anesthesiologist, especially in pediatric case. Yeah, caudal epidural is the most commonly done thing in anesthesiology. But in pain management, I think if you are talking about epidural steroid, means most probably we are talking about caudal epidural steroid, right? So what is the advantage of doing caudal epidural? Here you don't know any specialist like 2 needle. We no need of a lower technique, right? So you need just a simple needle, long needle. So we routinely use Venflon stillet. So that's 18 gauge Venflon stillet is good enough because it has got lateral line. So even if your needle is hitting the bone, there will be a lateral line there you can inject off. So another thing is nothing to worry about dura. Until S2, there is no dura. No need to go by millimeter. Just in centimeter. Just go. Just cross the S3, keep it there, keep it in the midline, inject contrast and do it off. So even S2 have a good margin. So if you are reaching S1, you may puncture dura, but we always say, okay, keep it at the level of S3. It's a very simple procedure, nothing to worry about dura, nothing to worry about meninges. Just only thing is you have to enter into the caudal epidural space. Again, the disadvantage is, so you can't do it for any pathology at the level of L4 and above. For example, you should not do it for L3 and L4 because we can't inject that much volume to reach L3, L4. So because the sacral canal is the least resistant structure, so even if you start injecting, it can accommodate 20 to 30 ml. Sacral canal itself can accommodate 20 to 30 ml. It's very difficult to inject that much volume to reach L3, L4. But still, it can be tried. If you're not able to do interlaminar, if the patient is not willing for interlaminar, then you can try, or you can put a Rax catheter, or there are some Korean catheters where you can navigate, just go there and inject there. Second thing is, though I say this is the most commonly done procedure, we usually do it at the patients above 60 years, right? 60, 70, sometimes 80 years with scanner stenosis. Those patients will have calcified sacrococccygeal ligament, and sometimes there will be osteophytes. It will be very difficult. It's not that much easy as doing interlaminar. Interlaminar, just we have to go hit the lamina, just move it up, or you can go in the midline, just feel the your ligament, then you just use the SLO technique and go there. Sometimes it will be very difficult when you're doing in aged patients. It's very good in young patients. For example, if the patient is coming for discogenic pain, caudal epidural steroid, I think it's very easy procedure. Just a matter of minutes, we'll just come out of the procedure. Third thing is sacral canal is highly vascular. So even if you are just going and keeping at the needle of S3, aspirating of nothing coming up doesn't mean it's intravascular. I had seen it very frequently in my practice. Okay, if I aspirate, nothing comes off. If I inject contrast, you can see the drugs nicely spreading in the venues, right? So there is more than 30% chance of keeping it intravascular. Again, I already told it's a big canal, right? So you need more volume. For example, you are doing interlaminar, you need maybe hardly 4 to 6 ml. For example, if it is L4, L5, just put your needle at the L4, L5, just 4 to 5 ml is good enough for those pathologies. But for example, if the same structure, same pathology, if you're doing by caudal, you need minimum at least 6 to 8 ml. So it slightly needs more volume. So more volume means you are going to dilute it more. Second thing, you are adding more local. So unnecessarily we are just going up. It's not clinically so significant, but still, if the patient already has some multiple canal stenosis, you are just going on increasing the volume, it may aggravate. Okay. So caudal, as again, we'll go for caudal. You no need of special needles, no need of worry about dural puncture, right? Coming to the interlaminar, it's very commonly done by anesthesiologists. Most of anesthesiologists are very expert on doing this one. The main advantage of interlaminar epidural is you can do it in any position except supine posture, right? So you can do it in prone position, lateral and sitting posture. So those patients who are not able to sit, lie, you can make them to get it sit and you can do the procedures. It can be done for any level pathology. Nothing, level doesn't matter. Even if it is L3, L4, L2, L3, you can do it off. And one more thing is you need an LOR technique, right? So we can't just go like caudal epidural, just go and keep it there. You can't, for example, you can't keep it in lateral view, just cross the lamina, you will get epidural. No, you need an LOR technique. The disadvantage of is, so we always should be very careful. Whenever we are going to use a bigger needle, the epidural hematoma chances are more with this interlaminar. So you always should be aware. For example, I had told you in any level you can do it off. Yes, you can do it off with CM guidance or with ultrasound, but only thing you should be aware of normal cord enlargement. You can't do it in L1 and L2. If you can do it, nothing wrong, but only thing you should be very careful. So in case of cervical region, you should be very careful. In case of thoracic region, again, you should be very careful because there the epidural spaces are very less. Okay, we should be very careful in moving those structures. Again, even though we are using a lower technique, there may be a minimal chance of dural puncture. Okay, if you are injecting a drug, in spite of injecting in the epidural space, if you inject anything in the arachnoid space, it's going to be nightmare for the patient. It will cause severe arachnoiditis. Okay, so again, for example, I already told if the patient has got L4, L5 canal stenosis, you are going to inject at the level of L4, L5, there may be a chance you may aggravate. Okay. So these are the, I can say these are the indications that it has got, it's a negative recommendation. You are not supposed to do that. For example, if the patient got L4, L5, just do it on the lower level. But only thing, you should identify the level normally. Just palpatory method itself is not adequate. You have to use at least ultrasound or CM machine to locate that level, right? So this is about the interlaminar, transforaminal. Yeah, it's the procedure we usually do it for radiculopathy, right? Those patients who has got radiculopathy symptoms, it's have more diagnostic value. The caudal and interlaminar, they are more of therapeutic. Just we'll go put steroids and come out. Here, we can do local anesthetic and check out whether the patient has got the same radiculopathy. For example, if clinically I'm saying it is L4 radiculopathy, if I put local around L4, the patient should have pain relief. This is the most confirmatory test for pain syndromes. Okay, so MRI and CT are not going to help. It's not the confirmatory test. It just gives you a clue about the patient's disease. So it is the diagnostic value it is going to help. You need less volume for those patients. If, for example, you need 2 to 3 ml for transforaminal, and if you have started doing transforaminal frequently, you may do advanced procedures like DRG and endoscopic discectomy. For example, if you start doing transforaminal, if your skills goes on increasing, then you may advance yourself to endoscopic discectomy. Again, the disadvantage is don't do transforaminal above L2. You can do it at the level of L3, L4, L5, S1, S2, but don't do anything above L2 because we had got major artery like artery of Adam's case or any segmental feeding artery. If you injure it, it's going to compromise on the patient's life, right? So don't do above L2. There are some people who say that, okay, you can do it. You can do it with ultrasound, then you can confirm with CM machine. Yes, this is for those patients who are persons who are practicing for years. Those have got good skill in needling, but it is not advisable for those who are going to start your practice or those who are in the young stage of your practice. Again, you can't do any transforaminal just by blind technique. Just you can't do it like go and hit the articular pillar, walk it down. Don't do it off. You always have to do it with either ultrasound or CM machine. CM machine is always better than ultrasound machine, so you have to do it with ultrasound CM machine. Okay. Again, just a summary of technique. So for caudal, it is the most commonly done by pain physicians. You have to do it for any pathology below L4. We don't need any special needles or syringes, and we need CM machine with contrast control, right? For interlaminar, you can do it for any pathology above L4. Even though we can do it with a low technique, the ideal thing is always use CM machine and contrast control. So I'm just saying contrast control. Contrast control means before you inject any epidural steroids, it's mandatory. Okay, just like that, you are just going and getting a loss of resistance, and you can't just inject steroid. Okay, you have to confirm. So without confirming with contrast injections, don't do epidural steroids, right? If it is intravenous, it's okay. The patient is saved. If it is intra-arterial, so the patient's life is going to be horrible for the life. Okay, right? So transforaminal, we always do it for radiculopathy. For example, the patient has got radiculopathy. The first option will be transforaminal, then CAR, right? So these are the steroids we routinely use it in our practice, right? So in India, we had got these 4-5 drugs: hydrocortisone, methylprednisolone, triamcinolone, betamethasone, and dexamethasone. These are the steroids we have in our practice. So mostly, if you ask in pain physician, which is the steroid we use, so most of us say methylprednisolone. Okay, so I don't know the reason behind it, but most of us are trained in that way. But if you ask an orthopedician and neurosurgeon, they will be saying triamcinolone, right? But just understand there is no difference between these two drugs. But the only theoretical possibility is it has got some sodium retention capacity. Other than that, it's almost both are equivalent. There is a lot of debate between methylprednisolone and dexamethasone. Which one will be the better? That will be coming up slowly, right? So these are the particle sizes. So when you look at this, there are, if you're not worried, we don't know what form of drug. So only thing you have to see what is that methylprednisolone, acetate, acetonide. Those will be in a suspension form. So for example, if the drug is in phosphate, so those will be water soluble. That will be very clear. If anything in acetate, acetonide, it will be suspension form. Okay, most of us will be using this drug. So most of you know this brand Depomedrol. Nowadays in India, it is not available. It has been stopped for long back, almost 3-4 years. We had got only 2 companies in India. We are supplying methylprednisolone, that too in suspension form. So there we are not sure what was the compound, because when you look at Depomedrol, they had got a lot of preservatives like polyethylene glycol, polysorbate, these benzyl alcohol. But in Indian, the drugs which are nowadays available in India don't have these we don't have these additives. I don't know why. They just write it is methylprednisolone and water. So I don't know whether they have it or not. So what is the importance of these additives? These may be the important thing for your allergic reaction. So whatever the compound we here, they may be the responsible thing for allergic reactions. So usually steroids, here is a drug of choice for your anaphylaxis or allergic reaction, but sometimes even these drugs can cause allergic reactions. It may be because of these additives, right? Just this is about the steroids we are using. So we are coming for the discussion of the most important thing. When we had started practicing pain management, I think it is 1990s to 2000. I think most the young first generation pain physicians started practicing in India. Then we had got generations coming up, learning a lot of things. In 2014, I think it was at the time where we are talking more on pain. In 2014, the FDA has issued a letter that injection of corticosteroids in the epidural space of the spine may result in rare but serious adverse events, including loss of vision, stroke, paralysis, and death. It's available in online also. Okay. So nowadays we are living in online era, right? So most of the patients, if they're advising steroids, they will just go and Google it up and they will come back, sir, FDA has given this warning. What can be done? Okay. So I think this was one of the most important hindrance for progress of pain medicine. Then a lot of debates came, there are a lot of articles came back, there are a lot of debates. Then still FDA has not removed that epidural steroid. Epidural steroid can be used. They don't say don't use it off, but it is an off-label use. It's not for, it's not labeled for example, Depomedrol is not labeled for epidural space. I still remember the Depomedrol by Pfizer, they used to have a warning in it, not for epidural injection. Though we use it for epidural, if you read the pamphlet inside, it has the word that not for epidural. Nowadays in Indian drugs don't have that marking, but Depomedrol by Pfizer has got that warning. So then we had a lot of discussions. Why this happened? Why these things are happened? There are a lot of debates going on. Then they found out, okay, it's again the debate is FDA don't have any rights to say this procedure should not be done because they don't have control over any procedures. They have control over food and drugs, nothing more than that. So they told you should not do epidural steroid injection because it harms more. Then the studies came back and told that, okay, it is not the epidural steroid, it is a technique. Now, most of the complications which are causing is not because of this steroid. It is because of the wrong technique. So most of them are done blindly. Second thing, it is done transformally. So without injecting contrast, without image guidance, if you are doing, especially in the cervical region, though we can say you are just, without contrast injection, you are injecting with just by ultrasound machine, then there may be a chance of all these things. Okay. So now they had told, okay, fine, you can do it, but do it with image guidance. So that was the inference at last. Again, there was a debate between, okay, why to use suspension form, use water soluble, right? So nowadays there are a lot of studies saying that, okay, in spite of using methylprednisolone or depot form, use dexamethasone. The results are okay, are comparable. So there is significant, we can say it also produces significant pain relief. But again, those who are already practicing in pain management are very comfortable with depot steroids. I think it was most of theoretical value. They say, okay, at least it will stay there for 3 weeks and they will have a better results. But there are still a lot of articles coming out with water soluble. Again, we'll go for side effects once FDA has issued it. So now we start with why FDA has given these things. Okay, most of the side effects are because of procedure. Okay, so what are the procedure complications? If you look at this is the whole list in 10,000 patients. Okay, it's a significant number. It was even given before FDA's one. It was done in 2012. Okay, this article has been done in 2012. FDA given in 2014, then 2015 multitask workforce, everything has started discussing those things. But if you look at these complications, okay, the most common thing will be your bleeding. It's not because of drug. It's because of the procedure, because we are using a bigger needle. For example, if you use a small needle, if you are using 20 to 23 gauge, you may not cause. But here, mostly with interlaminar epidural, we have to supposed to use a bigger needle. For example, you have to use 16 gauge or 18 gauge. 20 gauge will be very small. We can't reach it off. Even if you are doing, for example, if you are doing the same patient with sitting with LR technique, you may reach the epidural space in 4 centimeter. The same patient in prone position with C-arm machine, you may reach it in 6 to 7 centimeters because you are going to because of the lordosis. It's very difficult to correct the lordosis with prone position. So again, we have to use a long needle and a bigger needle. So the most common complication for epidural steroid is bleeding, nothing more than that, right? So the remaining thing like infection abscess, it's almost literally zero. So it's not more invasive procedures. We are always worried about infection in few patients, like those patients who has got uncontrolled diabetes or immunosuppressed. So these are the patients who we are always worried about. Again, we never give antibiotics for those patients who are undergoing for any intervention other than like trigeminal where you are touched dura. Other than that, we never give antibiotics. But we specifically give antibiotics for patients like those who are uncontrolled diabetic. For example, who has got always blood sugar about 200, immunosuppressed patients. Those patients who are on immunosuppressant drugs are those patients retroviral positive, then we give antibiotics. So even though I say we can give antibiotics, there's still the scientific reason behind it. It's for our personal safety, nothing more than that, right? Then, so we had got few other side effects because of the drugs. One is allergic reaction, I had told mostly is because of the additives, immune suppression, right? So if you are giving a steroid, we always worried about, okay, if you give some injection, what will happen to the immunity? So it has been shown even those patients who are undergoing like a shoulder intra-articular injection always defer any major surgery at least for 6 weeks. Right. So, for example, if the patient has undergone intra-articular steroid, don't go for laparotomy. Okay, you have to wait at least for 6 weeks. Or we can put it in the vice versa. If the patient is going to undergo any major surgeries, don't do any steroid injections. Again, the third thing is hyperglycemia. Those patients who are diabetic, we always worried about you are giving a steroid. What will happen to the blood sugar? Just relax, nothing will happen. So usually the blood sugar elevates slightly on the 2nd day to 6th day. But I had seen not that much significant. So I always have the habit of seeing blood sugar on day 3. I just ask the patient to do blood sugar, fasting blood sugar on the day 3. Most of the time it won't fluctuate that much. Even those patients who are elevated usually comes back in 6 days, right? The fourth thing is bone demineralization. So if again, we can say if you're injecting in the tendon, they say it will get weakened. What will happen if you're injecting in the spine? What will happen to the bone strength? Yes. If you're injecting epidural steroid, your fracture chances goes up by 31%. Okay. So, but still there are articles says that even with 3 injections, the osteoporotic chances are very less. There are some articles says no, even with single injection, it can go up by 31%. I will say epidural steroid, yes, be careful those patients when you are injecting in old age patient. So in a young patient, okay, it's not a big issue, but in case of old age patients, always be careful. It's relatively less when you are doing epidural steroid, but still there is a chance of vertebral weakening and vertebral fractures, right? The last thing is HPA suppression. We always talk about this HPA suppression, how much dose we can give without HPA suppression. Everybody knows it's 5 milligram methylprednisolone and more can cause HPA suppression. If you look at this slide, you can understand this one. So if you are giving methylprednisolone, the average suppression will be with single injection will be 1 to 3 weeks. Sometimes it can extend for months. So the most commonly done will be for methylprednisolone, but we don't have data at present for dexamethasone. But still, mostly we do with methylprednisolone. Its average will last for 3 weeks. Suppression will be there for 3 weeks. What is the advantage of why we are worrying about HPA suppression? It's not that much. In a normal life, it's not that much important, but those patients who are going for some stress like fever, or those patients who have got some infection, so those patients who are going for surgery, there we should always supplement. So that's the most important thing we are worried about the HPA. But we always say, if you are giving a single shot of epidural steroid, it obviously lasts for 3 weeks, right? But you are going for multiple, it may last for months. It can last for 3 to 6 months, right? Okay, what is the recommendation? Present recommendation for epidural steroid. So those I had seen a lot of people who are doing pain practice. They always have for example, the patient has got PAVD L5S1 with L5 radiculopathy. What they do caudal epidural steroid, then they put root block. Okay, it's not advised. Okay, if you want to do procedure, do only one procedure. Either do caudal or do transfemoral. Or you want to do interlaminar, do interlaminar. Again, interlaminar, for example, the patient has got multiple disc bulges. You can't just put one at the L4, L5. Again, you cannot put it in L3, L4. If you want to put, you have to put it at only one level. And if you are going for transforaminal, you can do it at the maximum of 2 levels. For example, you are going for bilateral, you have to do it at the level of 1 level. For example, L4, L5 means bilateral L4, L5, you have to do it once. Again, if you are injecting transforaminal injections, you are not supposed to inject more. For example, there is some intention of, okay, let me put it in the L4 and I will try to put 4 to 5 ml, it will go up. You should not do it off. Okay. So you have to maximum inject around 2 ml. So can we repeat the steroid injection for those patients? Yes. You can't get 100% results in most of the patients, right? Again, there is a debate whether it's going to respond or not. Even if you get, doesn't mean you will get 100% pain relief. So there are a lot of societies comes up with different algorithms. So, okay, do it at 6 weeks, do it with 2 weeks, like that. There are a lot of things going on. But just from the pharmacokinetic, for example, we are using methylprednisolone. It says that we always says that, okay, if you are injecting methylprednisolone depot form, it stays for 3 weeks. So our practice is just we repeat injection every 3rd weekly. We never make it as a mandatory injection. We just inject the patient, just ask the patient to come back after 3 weeks and see how much is the pain relief. If the patient says, I'm having 80 to 90% pain relief, that means it's okay. Don't do anything. Don't do any intervention. Just put the patient on physical therapy and get back the patient. If the patient says, I'm having 50%, then I may repeat the injection. I repeat with half the dose. For example, I injected 40 milligram of depot steroid or Depomedrol, then I will be injecting 20 milligram of Depomedrol. You have to put dose, you have to half the dose, because we should be very careful in putting the amount of steroids also. Again, and I reevaluate the patient after 3 weeks, then I will see how the pain relief was. Again, if the patient says, I had got result improvement, but still I'm not getting 80 to 90%, then I will repeat it off. The recommendation in most of the books says you can go up to 5 injections, right? Some books says it's 6 injections in a 1 year duration. But in Indian practice, I think we as a group trained under the Gautam Das, we always say Don't go more than 3 injections. Okay, so 3 injections is the maximum injections we usually go for. And again, for example, the patient you did 3 injections. Again, the patient comes back after 8 months and says, I want injection. Again, don't just go directly for epidural steroid. Re-evaluate the patient. If there is the same pain, again, you have to again put the patient again on conservative. If the patient is not responding, then you can go for this epidural steroid injection. Again, the debate is whether I get to go for depot or soluble. Yes, for lumbar regions, sacral regions, you can go for depot steroid, but make sure you are doing with ultrasound or CM machine with contrast control. If you are doing it blindly, don't use depot-minerals or depot steroids. Use dexamethasone. That's more than enough. You have to inject 4 milligram of dexamethasone. If you want to inject local, that's up to you. So adding local in epidural steroid injection is not going to have a significant difference for the patient. It's just a matter of few minutes to hours. So nothing significant. Just you can just go for dexamethasone. Again, the debate is whether to go for blind or image guidance. 100% you have to go with image guidance. Again, the debate is whether the CM or ultrasound. I will say if you are going for spine pathology, CM is the best. Okay. One thing is, even with ultrasound, you need CM machine as your partner. For example, if you are keeping your needle under ultrasound guidance in the epidural space, and before you inject, you need a contrast injection. The combined technique is always the best, because when you are using CM machine, the radiation hazard is always there. There you can use ultrasound machine to keep the needle at end position. Then you confirm with CM machine. That's the best way to do it off. So how much dose we can give? There are a lot of recommendations, but from Manchikanti, it was 3 milligram per kilogram of any steroid. Okay. Or it is 210 milligram per year or 420 milligram per lifetime. But I don't know what was the scientific basis for this recommendation, but this is a recommendation. I don't have any reason for it, but I found out most probably because if you increase this dose, there may be a chance of HPA suppression. That may be the one reason I just found out. Again, the textbook itself mentioned this word and they will say without scientific evidence. I don't know why, but this was the recommendation. I don't know the reason behind it. Still, I follow this. So 210 milligram is significant. For example, you are using 5 ml of depot steroid, like methylprednisolone, that is 5 ml. That's good enough for a patient, right? Again, the frequency I had told, there are a lot of debates from different societies, different protocols, but we always say go for 3 injections in 3 weeks difference. That's good enough. That's I can say that makes sense for an Indian patient, right? And again, there are some people who do every week, like especially in the Korean society. If you are going for Korean people who are doing intervention, there we can say they do it very frequently, every weekly. That's not recommended. You can't do the procedures which has got some complications which patient can have. You should not do it. You have to wait for the drug to act. At least 2 weeks is required for steroid to act. So you have to wait at least 2 weeks. So we keep it as 3 weeks because we expect that the depot steroid will stay for 3 weeks, and that was the maximum duration that it can work. Right? There are different recommendations. When you look at the recommendations from different societies, you can see what is the medical politics. Okay, those recommendations by physician societies always says epidural steroids works too good for short term and long term. Those for physician society, they always say don't do. It has got complications. Don't do. So I don't know what was the basic behind these societies just fighting among each other, saying this is best. And I will say, okay, it's the person who does and recommends that's good. If physicians don't do those, they just take out the literature, just review the article and do it off. A pain physician does it and he sees the patients and he is the better expert than a physician group, right? So I always follow this society groups. And if you look at the neurosurgeons, they will say, yes, you can try conservative and you can try and explain the patient. That's very important. That they used to say, explain the patient and do it off. So I will say epidural steroid is good for patients if you select it properly, right? So how to select the patient? That's the main important thing, right? For the patients who are having acute radiculopathy, yes, it will work. So how much time you have to wait for conservative? I will say you have to wait at least for 6 weeks. Okay, just you can't put for a patient having pain for 1 week, patient saying I am not able to do any activities. Don't do it, right? Wait. the disease itself, our body itself will defend our disease, right? So give some time for the disease to act, our body to defend. You have to wait at least for 6 weeks. Sometimes if the patient comes to me in 1 week, I wait for another 1 week, at least for 2 weeks. So you have to, that is a minimum period you have to wait. So you have to wait for 2 weeks and see how the patient is. If the patient says, I'm having pain relief, but not that much significant, then also you can wait for 6 weeks. If your patient says, I am getting it more aggravated, then you can try for this epidural steroid, right? So this was one of the words given in this insurance company, the Medicare services of USA. They say, they have an article for epidural steroid recommendation. They say there are different articles and we are finding it difficult because it's like in comparing an apple to an orange. There is no standard protocol in any of these articles. They will say they use different compounds, they use different techniques, they use it for different indications. Sometimes there won't be non-specific indication. It's very difficult to compare all these articles. There are a lot of articles if you search out, there will be a lot of articles for epidural steroids. There some people will say it works, some people will say it won't work. Then you have to rely on some society to come up with systemic analysis and come out what will be the recommendation. They found it is very difficult to recommend because the articles are not great. They will say there are different RCTs with the different techniques. It's very difficult. But still, most of the societies accept that. Okay, epidural steroid will give some short-term pain relief. For example, the patient is having pain for 6 weeks, and if we give it, it will at least give relief for 3 months to 6 months. This is the most commonly used words. But is it very significant? Yes, it's very significant. If you are suffering from radiculopathy, then you can understand what is the significance of this short term. Okay, our body itself will defend. For example, if you are giving analgesics, you are getting pain relief. After 3 weeks, your body will get itself tuned, or they will defend itself and make you pain free. So if your drugs are not responding, you have to give some more chances for your body to get it defended. So if you're giving an epidural steroid and the patient says, okay, I'm getting pain relief, then our body itself will take care and they will have sometimes long-term pain relief. They will have pain relief for long-term. So what is the common things we do? We take a patient of pain with 10 years and we do epidural steroid and we expect patient should have pain relief for years. It's very difficult, right? So because most of the time it is not a nociceptive pain, it will be a neuropathic pain. So it is very difficult just putting an epidural steroid in a neuropathic pain and you are expecting the patient should have a pain relief. Yes. I had last week I had a patient who was suffering from back pain for the past 10 years. It's typically a neuropathic pain. I told them, okay, you have tried everything. He has been tried even alternative medicine, even massage therapies, everything she tried. She came back to me and told, okay, I'm suffering for years. I need some relief. I told them, okay, I can break your pain cycle, but I don't know whether it's going to respond for years. I just gave a shot of epidural steroid. To the miracle, she has got very good pain relief. And again, I just say this is case of exception. Okay, don't believe, for example, you are doing some cases with 3 patients, 4 patients with chronic pain for 6 years to 10 years and you get good results. Doesn't mean it works. It's a drug which has a miraculous activities. No, it won't have that much miraculous. It does some work in some patients, but most of the time these patients they used to come back after months. Okay, so the epidural steroid for those patients with chronic pain, if you are doing epidural steroid injection, you just make sure to the patient you are just going to break the pain cycle and it is not going to give you relief for some months, 2 years, something like your lifetime. Only the physical therapy is going to help you. Again, those patients with neuropathic pain, epidural steroid is just a part. It's a small part of your management. It's the physical therapy which is going to be the major thing which is going to help the patient. Again, if you're going for a steroid injection, always discuss with the patient. Just don't give false belief that if you're having radiculopathy, if I put steroid, you will get magical relief. Don't give this false belief. Just explain the patient, right? So these are the things which you will expect. For example, I will give you a steroid for you because the drug has failed for the last 6 weeks. I will give you a steroid injection. It may help, right? So I have to wait for at least for 1 week for the onset, at least 2 weeks to infer whether it's worked, and 3 weeks to repeat. So this is the words we routinely use it of. So after 3 weeks, if I assess the patient, if the patient says pain relief, yes, good, you have got the good relief, but only thing, it's not going to sustain just by injection. You have to go for physical therapy. If the patient don't go physical therapy, again, it may be a chance that they will come back after a few weeks and they will say, sir, I got the same pain. So if you want the sustained pain relief, it's not the epidural steroid. Epidural pain steroid is just for breaking the pain cycle, right? just coming for the last slide. Epidural steroid injection, if you are doing in your practice, make sure you are doing it as an expert mode. So you know why you are doing it. What was the indication? Is the diagnosis right or not? If somebody is referred to you, and make sure that's the same diagnosis. So just don't do it like in technician mode. Just some department sending the patient for epidural steroid, just going and putting, it don't help that much, okay? Because there is a more chance you won't learn, okay, why you are doing, what was the results, you won't learn it off. So don't do any epidural steroid as a technician mode. Always do it as an expert mode. We have got the expertise. Only thing you have to read, you have to learn something beyond anesthesia. Again, if you are doing epidural steroid, don't do it blindly. Okay, I had seen a lot of people doing blindly. It's not because of there's a problem, because they don't have CM machines. So they don't have access to CM machines. But start learning with image guidance. Or if you, nowadays we have got a lot of ultrasound machines, right? So at least try to put it with the ultrasound machine. But if you have a chance to have a CM machine, that's too good. And again, always inject contrast. So again, there is a debate which contrast to use. Most of the OTs will have urographin, right? So don't inject urographin. So you have to inject water soluble. Ultravis. There are a lot of water soluble contrast. Don't inject urographin. You are going to compromise on patient's life, right? Again, if for lumbosacral regions, yes, you can use depot steroid. In thoracic and cervical, water soluble. That's a good option. But if you are going to start your practice, use only water soluble. It's always have the same, almost equivalent results like a depot steroid. So use water soluble. And don't do transforaminal above L2. Even I will say, even with expert hands, there is a chance of injuring your segmental artery. Okay, so don't do anything above L2. So if you are doing in a patient and you are getting results, that's good enough. You are too good. But if you have a complication, you can't defend, because the textbook says don't do above L2. It has got negative recommendation, but by multiple societies. So it's easy to just point out, okay, this has got a negative recommendation. Why did it, right? So don't do above L2. And if you are doing by transforaminal, you heard of Cambine's triangle, right? So Cambine's triangle is the safest triangle. It's not the safe triangle. That subpedicular pitch is not the safe triangle. Cambine's triangle is the safest triangle to do with. And I will say, if you want to do epidural steroid, do it interlaminar as you are doing, but always use a CR machine. But you want to be more, if you want to be more expertise, start doing caudal epidural and CM guidance, do it off. And you are expert in caudal and interlaminar, start learning transforaminal. Okay, so do transforaminal. Those patients who has got radiculopathy. Just for discogenic pain, don't for just clinic. Just for if the patient has only back pain, don't do transforaminal. Do only interlaminar and caudal. If the patient has got radiculopathy, do transforaminal. And thank you, the team. So any questions? I am here to take your questions.
Thanks, Guru. Thanks. It's a very excellent presentation, right from the basics to the current concepts. You explained the things very well. Have some queries, but some of the queries you have already answered for others' queries.
Okay, I didn't see.
I just want to ask you one thing. You emphasize that you love to do it with spinal needle rather than epidural needle. For
caudal, I prefer caudal. I always use Venfron steroid. So if you are using spinal needle, the stiffness won't be that much. If you are using 22 gauge, it will be stiffness won't be that much. I use 18 gauge Venfron steroid. So the stiffness will be good. Again, it has got a lateral eye. So even if you are injecting, if there is something resistance there, it will take out from lateral eye.
Okay. See, actually, can I make a small comment on your this thing? You told that combining ultrasound and fluoroscopy is best, but I want you to tell it's a must. It's a must. So even when
you are saying it's a must.
Even if you do it under ultrasound, the fluoroscopy check, contrast check is must in epidural injection, because you only told that even in caudal we have seen lot of the times it has gone into the this thing venous plexus and other things. So when you do ultrasound guided injections, You prefer lumbar transforaminal better under ultrasound or fluoroscopy if you are being given a chance?
So I always, spine means my first option other than SI joint and the S1 root block. My first option, S1 I will try with ultrasound because it's very easy to do. And in transforaminal, I always, in lumbar region, I always very comfortable with CR machine. Maybe I think if I start using it, maybe I will be comfortable with the ultrasound, but I always feel CR machine is better for lumbar procedures. But there are experts who do transforaminal with ultrasound. But as per my experience, I will say CR is the best.
You mentioned about the Campbell's triangle and subpedicular approach for this thing. Can you emphasize why you want to prefer Campbell's triangle always?
Okay, so I think I missed that presentation slide, right?
No, you.
So if you look at this slide, right? So this is your transforamen. You have got now. If you say this is, you divide this one into three structures: upper 1/3, middle, and lower 1/3. Okay, if you divide from cranial to caudal, you can make it as 1/3, 2/3, 3/3. So you can make it as three. We can split it in three. The upper 1/3, which we do it in subpedicular approach, just below the pedicle. If you just go, we inject, right? That was the classic approach. We do it. They say a safe triangle approach, subpedicular approach. Usually we say it's safe, but there is a chance it may get some veins there. So usually it will get some veins. Sometimes you will get a segmental artery there. So that's not a safe triangle. But if you're going below here for lower 1/3, there you won't get any veins, any artery. That's why we say Campbell's triangle is very safe. The only thing if you're doing for subpedicular and Campbell's is, for example, you are doing for Campbell's. For example, the patient, if we say this is L4 and this is L5, this is L4, L5 disc bulge, and you are doing by Campbell's triangle, be careful. You are just going exactly at the pathology site, right? So if you are just going and exactly at the pathology site, you should not use more volume. You have to inject very less volume. 1.1 to 1.5 ml is more than adequate. Again, you are just going to inject exactly at the pathology site. That you can expect the drug to be more effective. For example, if I am injecting in subpedicular, for example, the patient has got radiculopathy here, I have to inject from down and I have to push the drug up. Okay, so that was another advantage of Campbell's triangle. Campbell's triangle advantage is we don't have any vessels there in Campbell's triangle, that is lower 1/3. Second thing is we are just going to inject exactly at the pathology site. So you need less volume and better action for the drugs. It's more of theoretical. I will say the better action is more theoretical, but I always say always try the best theoretical thing.
If the patient has come up with a post-laminectomy syndrome with instruments in situ, which route you will, which instruments in situ, pedicular instruments. So what route you will prefer for that type of patients?
So mostly those patients who has got a failed back surgery, if you are saying post-laminectomy with the instrumentation, I always preferably go for caudal epidural. So that will be the best thing to do for. So if you want me to, for example, patient is having typical radiculopathy, yes, I can try transforaminal, but instrument is not a big issue, sir. Whenever you are having a CR machine, you can change the angles, different angles, and you can find the space. But again, I will try Campbell's there. So nowadays, I stopped doing safe triangle approach. I am started doing only Campbell's triangle. I think for the past 6-7 years.
Vishnu has made a comment that ultrasound will confirm the needle position. No, the issue is not with the needle position, Vishnu. When you do a caudal, you start visualizing the needle after you enter into the bone, because bone window will obstruct the needle visualization in ultrasound. That's why I emphasize that always it should be hybrid and fluoroscopy with dye. After that, you can inject steroids. Okay.
Ultrasound is a good thing. Ultrasound is a good thing. Yeah, there is a lot of debates going on. But again, as Rajesh told, I told the same thing only. You have to inject contrast. So contrast plays a major role. There is no contrast for ultrasound at present. Only the air bubbles are the only thing which you can use it as a contrast. And again, there are some people says, okay, you inject, start seeing something on the interlaminar window. Those are, I think it's very technically difficult to do those things. Better you just go for a single set of steroid. Yes, you can do those techniques for those people who are allergic to contrast. There are some indications like the patient is, you can't use CM machine, you can't use contrast. Those kinds like pregnancy, then you can use those techniques.
Can you emphasize on the volume? How much volume you use? So you told 2 ml for transforaminal. How much for interlaminar? How much for caudal epidural?
So I always use 6 to 8 ml. So usually I decide when I inject contrast. So I never premeditate that this much ml I will give. So what I do, I just put it as a needle at the S2, S3 level. I inject contrast. So usually my contrast will be 1 to 2 ml and see how much it is going up. Okay. So if the 1 to 2 ml, for example, 2 ml, it is reaching L5, I hardly need 6 ml. That's more than enough. Because with 2 ml, it is able to reach, means I need hardly 6 ml. In interlaminar, I used to use 4 to 6 ml because we can say 1 or 2 segments. Usually they say 2 ml per segment. So 4 to 6 ml I use depending on the patient's condition. Okay, the patient has got 2-3 levels, I will use it around 6 to 8 ml. If it is 2 level, I use it 6 ml. If it is single level, I use around 4 ml. That's for added advantage that even something goes outside epidural, at least some drugs will go there. So I used to give 4 ml. For caudal, I always inject contrast and see how much I need. So most of the time, I won't be injecting more than 8 ml. That's the most important thing. Second thing is, very important thing when you're doing caudal, how much rapid you are giving. Okay, there is always a chance if you just go, when you're like an anesthesia, you're just giving drug fast, within 10 seconds, you may create headache for the patient. The patient may say, I'm having headache. Okay, so don't inject anything fast in caudal or interlaminar. You have to inject 2 ml fast, wait for 3 to 4 seconds, inject 2 ml, wait again for 3 to 4 seconds, inject. You have to inject either with increments or you have to give it very slowly over 1 to 2 minutes. That's the most important thing. If you're giving over 1 to 2 minutes, I think you find something, you are feeling like your drug won't reach there because I'm giving it very slowly. The drug will try to accumulate only in the sacral canal, but you are giving it very fast. For example, I just push it in 1 second, the drug moves fast. At least it will reach in L4, L5 level easily. So that's why we give it fast, 2 ml fast, wait for a few seconds, again give 2 ml, wait for a few seconds, again in increments you have to give.
If there is an inadvertent dural puncture happening during your interlaminar epidural steroid attempt, if you have injected steroids, what will happen? Or what will you do if you have an inadvertent dural puncture?
So inadvertent dural puncture is, I told you, if something, the drugs which we are routinely using, that methylprednisolone, depot steroids, right? So which has got a lot of preservatives. If you are injecting there may be a chance of chemical arachnoiditis. If you are inadvertently injected, means I will say you have to pray, that's all. Or otherwise, if you say you are damn sure that you are injected, there are some people say put in catheter, give wash, take off the drug, give wash and take it off. But I have never tried so far because I don't have that much experience so far in my life. Thanks God, so I didn't have. But I will say if you are not supposed to inject anything in subarachnoid, that's the most important. You should be very careful. That's why I say inject contrast, because it helps you in diagnosing whether it's intravascular or intrathecal. So then you inject off. So I will say even if you're injected, you put a catheter, epidural catheter inside the spinal canal, just use saline and get it washed off.
Incidence of epidural abscess following your epidural steroid injection?
So far it's 0. I think I had shown the previous studies also, it was almost 0. Thanks God, I don't know. Whatever the follow-up I had 0%.
Okay. I think we have taken up almost all the questions. Comment on arachnoiditis has been dealt by Vishnu. Yeah, it is. So somebody asked about arachnoiditis and clinical diagnosis of arachnoiditis.
Yeah, arachnoiditis, yes. The patient will have severe leg pain, especially on a nocturnal pain. They can't lie, they can't move off. This severe neuropathic pain. So it's like every nerve gets clumped off. So then you can expect how much pain it will be. So the patient can't have a particular position to have pain relief. They will have severe pain. They will have severe leg pains, and everything will be there. I had seen arachnoiditis in endoscopic discectomy.
Okay.
Rajesh, can I give an input?
Madhan, anyway, you are going to contradict all my versions related to ultrasound. I know that you are going to put
not at all. Not at all.
Okay. See, just 2 minutes. I think we are getting
related to this topic actually.
Yeah.
See, thing is like I feel all spine related transforaminal or caudal. There is always a role for fluoroscopy than ultrasound. Okay, that's fine. But at the time of needling, ultrasound always has a role, significant role to play. I think we are all talking to people from background of anesthesia. So I would personally suggest all your caudal epidurals, even in pediatric age group, must actually go by ultrasound guidance. I think that's the way to start actually doing a spine intervention with ultrasound guidance.
Definitely, yes. That's a most
Dr.
acceptable
Madhan,
point. That
nowadays I'm very comfortable entering needle with ultrasound.
Yeah,
So
that is
I
one
always
thing.
say,
No, not you. From the anesthesia department, I'm saying.
No, I am saying for those who are already practicing also, using ultrasound to enter caudal space is very easy nowadays than by using.
That is number one. And probably I think if you had shown some fluoroscopy images, probably like 1 or 2 steps for the beginners to learn, that would have been better.
That's okay. If you want, I can just show.
Yeah, please, one video, small video, if you have, please.
Oh, it's not. It's in the different.
No problem.
No worries.
Splanchnic neurolysis.
No.
Sure.
No, I will just come on my another system. I will just join back.
Yeah, you can join back because, like, I think the youngsters will be inspired by those small little techniques.
Yeah.
Okay.
Shall we move ahead with the next session, and then Guru will have the demonstration at the last?
Sir, give me 2 minutes. I will come back because I had some work there. Can you give me 2 minutes? Rajesh?
Okay.
We can hold on. Don't worry.
Yeah. Madhan, your take on, I do agree that ultrasound, the needle placement will be better with ultrasound. There is no doubt about that. But I still feel that for contrast injection and other things.
No, you need fluoro. 100%.
Yeah. Hybrid technique is always better and safe. So, what is your experience on ultrasound guided transforaminal needling, which is better with ultrasound or lumbar transforaminal needling?
Strictly no to ultrasound. Okay. Because all your median branch and facet joints can be done with ultrasound, but definitely not transforaminal.
Okay, because there are a lot of people those who do ultrasound guided needling. But
I don't advise actually. See, cadaveric needling practice is different. Real-time live patient needling is totally different.
Okay.
So we can't take a chance like that.
Yeah. Thank you. Because this is a very great message. Because you are the expert in ultrasound needling. So the great message to the society that.
No, we really can't say anything on a live patient. But with respect to cadaver, definitely we can say with respect to the dye spread. But I don't really agree with doing sole ultrasound guidance.
Yeah, but cervical. How about cervical?
Cervical transforaminal you cannot do. You can do an extraforaminal injection. Number 1. Number 2, definitely you can do a facet. You can do a median branch. You can do a stellate. You can do a cervical plexus. So all that can be done exclusively with ultrasound if you want to really. If you want to have a hybrid technique, definitely yes, you can do a hybrid. But ultrasound has got a huge role to play with respect to neck procedures.
Yeah, ultrasound outroots the fluoroscopy there and
absolutely.
Yeah.
If you want, you can actually do a hybrid technique. You can do a fluoroconfirmation, but not necessarily. Whereas with lumbar spine, you always stand a chance that you will always require a fluoroscopy backup. Plus, there are certain techniques which should never be attempted with sole ultrasound at all.
Okay. Guru, are you ready with your?
Yeah. So this is about caudal, right?
Okay.
So you can see this is a lateral sacral spine, right? This is a posterior sacral plate, and this will be your anterior sacral plate. If what you are seeing is a sacral canal.
Guru, 1 minute. We are not seeing anything, Guru.
We are not seeing anything.
Oh, wait, just.
I think you need to share it separately.
Yeah, I will share it again.
Yeah, please.
Yes, sir. Can you see now?
Yeah, absolutely.
Some-
Yeah.
So this is your sacral plate. So anti-sacral plate, posterior sacral plate, you can see the sacral canal. So we had to just infiltrate local. So you can see this is the Venfron stillet you are using. You can see the needle over here, and we are trying to enter into the sacral canal. The most difficult thing will be here. So if you once enter here, you are done. So it's very easy. So you can see this is the AP view. You can see the needle at the level of S3. You can see the contrast. This is called epidurogram. So if you look at here, this patient, you can see the drug is spreading only on one side, especially on the left side, right? So you can see that is some medial plica is there. So now what I am just going to, I will inject some more volume and see whether it is spreading on the opposite side. Again, if you are doing contrast injection, always do it in live mode. Just inject, don't take shot after just injecting. You have to do it in live mode. That's very important thing. So you can see the duct spread, again it gets spread to the opposite side here. So now I am comfortable, no need to reposition it, just I will go in with steroid injection. Okay, this is about steroid. Then I will go for your root. I don't have interlaminar steroid because most of the time I won't be doing interlaminar. Very rarely I will do interlaminar. So this is the root. This video, we had it in our video book. This is the subpedicular approach. So this is L5 pedicle. So we are doing with your fellowship candidates. So this video we took it when we are training some fellows. So this was done by my fellow. Only thing you have to hit this pedicle and you have to get down. So just we have hit the pedicle, we are going to get down. So this is a lateral view. This is your pedicle and you are getting our needle here. We have to cross the lamina just at the, we can say posterior, superior 1/3, we have to keep our needle. Then we have to inject. Again, we have to confirm in AP view, then we'll be injecting contrast. You can see the needle here, almost here. So this is the epi view. You can see the little tip over here. We inject contrast now on live. Now you can see the nerve. Exactly on the nerve. Okay. So this is a typical nerve appearance. So once you are confirmed, now you have to go for steroid injection. Hardly need 0.5 ml. That's more than enough.
Thanks.
Thanks, Guru.
Thank you. Thank you.
Thank you.
So sorry, I didn't put it because I thought of nothing to do with those procedures.
No, that's okay. That's fine. Sir, Edward, sir, if there is any other question, shall we move ahead?
No, we can move on to the next session.
Yes, sir. Okay. So the next session is about nerve entrapment syndrome. So what is happening new there? And it will be by Dr. Madhan Pandian, a very good friend of mine from my school days. Actually, we both are classmates and we were batchmates in, actually he was my senior in anesthesiology, and so he had done multiple works in this pain related to ultrasound, so sonology, and he is having a special degree for that, CIPS, both CIPS and RMSK. So he's an exclusive interventional pain specialist and MSK pain sonologist from Pondicherry. Over to you, Madhan. Please enlighten us on this topic, nerve entrapment syndrome, which is your passionate, I know that.
Thank you, Rajesh. Thank you, Dr. Edward, for the invite. Am I audible?
Yeah, you are clearly.
I think my slides are also seen, right?
Slides are clear, yes.
I'm basically an anesthesiologist. As Rajesh introduced me, I'm basically an anesthesiologist. Pain has actually really evolved. The department, the specialty of pain medicine has really evolved, and it has got multiple domains. I have taken up one such domain called musculoskeletal ultrasound and pain medicine, where the common problems of pain medicine actually comes from the musculoskeletal system. And out of these musculoskeletal system, there are some things which are very, very difficult to diagnose and treat. Once we make a diagnosis, I think like there is always a saying, you make the diagnosis, then it is very easy to treat. So nerve entrapment syndromes are the ones which are the most difficult ones to diagnose. That is where it becomes difficult to treat as well. So before I actually enter into the topic, I just want to tell you that we have a conference which is coming up, the MSK Pain Congress 2024 in Chennai, that is in Mahabalipuram. Please do register for this conference because this is going to be the benchmark for the future. We have nearly 49 faculty across the globe who are going to enlighten you on this subject of musculoskeletal pain and ultrasound. Okay. Someone has time, please go through these procedures, the ultrasound guided interventions, 10 most rewarding procedures. I had a conversation recently with Dr. Hatzig. We discussed about the most rewarding procedures. In those procedures, one of the most important is the nerve-related interventions, that is diagnosis of entrapment syndromes and treatment of entrapment syndromes. So how do we define the terminology? We are not essentially looking at the definition aspect of it. We have something called the structural abnormality of the nerve. There is a structural abnormality of the nerve, either intrinsic or extrinsic, compression, entrapment, or sometimes related to trauma. The entrapment neuropathies occur within the peripheral nerves, and it is characterized by the distribution of the nerve. That's the one which is affected by that chronic pain. Now, what are the common syndromes? As you all know, the commonest being carpal tunnel syndrome. There is something called cubital tunnel syndrome, that is ulnar nerve entrapment. Then the pin entrapment, that's supposed to intraosseous nerve entrapment. Guyon's canal, tarsal tunnel, meralgia paresthetica, which is entrapping the lateral femoral cutaneous nerve, and the Morton's neuroma. Today, I'm going to discuss only about a few syndromes like carpal tunnel, cubital tunnel, pin entrapment, and meralgia paresthetica, because I understand it's a lot difficult to take for particularly postgraduates and beginners in pain medicine. So what are the symptoms? There is a localized or a referred pain. Wherever the distribution of the nerve is, there is always some tingling or referred pain-like sensation. There will be a paresthesia, a burning sensation, and impaired movement can be there if it is a long-standing pain. And it can actually result in a myopathy, that is muscle weakness, muscle wasting, and dry, thin skin can be there in chronic cases which develop motor and sensory entrapments. So what are the etiological and risk factors? If there is a trauma, definitely, yes, there is always going to be some little scars, myofascial tension, bony spurs, arthritis, some cysts, systemic diseases like diabetes, acromegaly, hypothyroidism. All this can result in a nerve entrapment syndrome. Because nerve entrapment syndromes are so varied in signs and symptoms, causes and location, it is very, very essential for you to look for the detailed medical history and physical examination before you actually venture into treating the patient. So what are all the differential diagnoses? Sometimes somebody has a pain along the upper limb. It could be just a small little nerve lesion which is causing maybe a tumor, maybe a cyst, maybe a radiculopathy, or sometimes a peripheral neuropathy. A peripheral neuropathy is something which is probably not the easiest or not the very difficult ones to diagnose, because peripheral neuropathy is going to be uniformly distributed on both the limbs, and it is going to be like a glove and stocking fashion. Radiculopathy, you can always find out by doing a provocative test. Try to rule out a cervical radiculopathy or a lumbar radiculopathy. Try to see if there are any particular nerve-related distribution causing this particular pain. Now, we move on to a clinical situation where there is a 56-year-old man who is a non-diabetic, a cook by occupation, presenting with 2 years of history of right wrist pain along with severe pain of the radial 3.5 fingers. So this is the radial 3.5 fingers distribution of pain, particularly severe at night, which increases by specific activities like cutting vegetables and making samosas. So what is this particular pain syndrome? Because there is a radial 3.5 fingers being involved, you are most likely looking at a patient with carpal tunnel entrapment of the median nerve. So on clinical examination, you need to do all these tests, the phalanx, the reverse phalanx, the Durkheim's, the compression test, and the tunnel sign. You could see sometimes in advanced cases of carpal tunnel syndrome, the finger actually, this is called the ape thumb deformity because of the weakness of the thinner muscles. So how do you image? Because all your departments of anesthesia and pain medicine has got at least one ultrasound machine at your disposal. Try to look for these musculoskeletal structures whenever you have opportunity to see. You can do a good self-examination. You can try to find out and identify the structures and then go in for intervention and diagnosis on a patient. Exactly, this is what you need to see, the scaphoid and the pisiform on either sides, the scaphoid on the radial side and the pisiform on the medial side. Try to look for the connecting retinaculum, that's the flexor retinaculum, just beneath which you have a bifid median nerve. Here we have a bifid median nerve. One important fact which I want to really reiterate here is, there is always a learning in undergraduate that this is only an idiopathic syndrome. Never. Around 90% of your patients with carpal tunnel syndrome are either going to have a comorbidity like diabetes or a hypothyroidism or acromegaly, or sometimes they always have a bifid or a trifid median nerve, sometimes a persistent median artery. All these actually are secondary causes of carpal tunnel syndrome. So it is not essentially a primary disease. So you need to rule out, try and treat the primary disease before you actually going for any intervention or surgical procedure. Typically on the long axis examination of the median nerve, you can see there is a compressed median nerve. This is the retinaculum, which is compressing the median nerve, giving rise to an hourglass appearance. The proximal and the distal ends little dilated because of venous congestion. So what are all the interventional options? The interventional options are always, you have steroids. which has got very limited role to play and a short term, very little role to play and a short term role. It's probably a matter of 1 week to 10 days this will act. You have got 5% dextrose, which can be injected into the carpal tunnel. You can put in low doses of botulinum toxin on the proximal end of the muscles. That is the tendons, the FDS and FTP tendons are there within the tunnel. You can just proximally inject botulinum toxins around 50 units distributed along these muscles. PRP injections are very promising. Suppose if there is a case of severe carpal tunnel syndrome, when you actually make a diagnosis with both by ultrasound and nerve conduction studies, if it is severe, go for percutaneous release techniques. Exactly, for a mild to moderate case, which has got a median nerve thickness of less than 18 millimeters square, and who has got a mild to moderate severe carpal tunnel syndrome, you can go in for a carpal tunnel injection using 5% dextrose. I have just demonstrated a technique here. This is the medial to lateral needling. This is the scaphoid tubercle. This is the pisiform, ulnar artery there. And this is the retinaculum. This is the retinaculum under which I'm just injecting 5% dextrose without injuring the nerve and the nerve here. And this is the ulnar artery. Ensure that you don't damage any of these vital structures. Try to do a fenestration of this retinaculum. You could see the retinaculum there. Try to do a needle fenestration. I've used a very thin needle, a 26 gauge needle. And on the long axis, this is the long axis of the nerve. Again, injection of 5% dextrose underneath the retinaculum there. That's the retinaculum. And you can see the hydrodissected nerve. This is the nerve which is hydrodissected. And this is the flexor retinaculum. Nicely separated out median nerve. Means that around 10 ml of 5% dextrose is injected into the carpal tunnel. Four ml above the nerve on the short axis, 4 ml below the nerve on the short axis, and 2 ml above the nerve on the long axis of the nerve. Now, anyone would try to ask this question: what is the role of 5% dextrose? It has got both mechanical and pharmacological effects. The mechanical effect, actually, it is a fluid under force which lessens the adhesions and improves the blood flow. And increase in local glucose increase will cause stabilization of neural activity, regulates the glucose metabolism, and lessens the neuropathic pain. And there are multifactorial reasons why 5% dextrose can be used. So basically, I'm not going to explain all the reasons. So it has got both mechanical and pharmacological effects to cause reduction of the entrapment of median nerve. So what are the guidelines? You need to give 3 sessions of 5% dextrose injection, 4 weeks apart, around 10 ml of 5% dextrose each session, and do not combine steroids and PRP. Do not combine steroids and 5% dextrose. Always try to use one particular drug to gauge the success rate of these injections. There are some percutaneous techniques which are actually available. The Mayo Clinic technique, wherein you use the epidural needle, hook around 2-0 nylon and try to release the carpal tunnel in severe cases. You can use a Sonex Health. Again, it is available only in the United States and Australia. Probably next year we are bringing it. This is going to cost $250, where you have a small little knife, percutaneous insertion under ultrasound guidance, release it, something like a true cut needle it is, release it with a knife so that you could be successful. There is a percutaneous technique which is available for release of the flexor retinaculum even in severe cases. Moving on, this is another patient, 65-year-old orthopedic surgeon, who actually has ulnar tunnel syndrome, that is a cubital tunnel syndrome, where the cubital tunnel, in the cubital tunnel, you could see the ulnar nerve actually is swollen. The ulnar nerve is swollen, and this is because of a thickened Osborne ligament, which is roofing the cubital tunnel. Again, injection of 5% dextrose around the nerve. It's very difficult to see the nerve on the long axis. Ideally, it should be done on the long axis of the nerve. I have done it in the short axis of the nerve. Around the nerve, if you inject 5% dextrose, even if it is a little intraneural, you really don't have the chance of any neural injury. That's the advantage of using 5% dextrose. Posterior intraosseous nerve entrapment, I think most of you would have an access to ultrasound. As I told you, please try to look in for these peripheral nerves, because posterior intraosseous nerve entrapment is not so uncommon. You will have only a thumb drop. You won't have a wrist drop when you have a posterior intraosseous nerve entrapment. Here you could see this is the radius. These are the two heads of the supinator there, and you have a fibrofatty plane which contains the posterior intraosseous nerve, where I'm doing a hydro release with 5% dextrose. That's the nerve. Basically, in all these entrapments, you are basically doing a structural release of the nerve with 5% dextrose, or even steroids can be used. This is one important image where I think all of you could appreciate. There is an ulnar claw hand. There is a post-traumatic ulnar claw hand in a patient who is a very young fellow, a 30 years man, who tried to hold his bike when it was falling down. Not a very major injury, but he had developed wrist pain along with an ulnar claw hand, following which when we did an ultrasound, there is a small little irregularity. There was a query hamate fracture. He went in for a CT where there was a hamate fracture, rather. There was a hook of hamate fracture, for which he had to undergo a decompression, a surgical decompression. And you could see it got corrected. The ulnar claw hand got corrected. It's not essentially an entrapment which you are trying to diagnose and treat here. You are trying to treat all these neurological conditions, the neuropathic conditions rather, either by interventions or by surgery. One very important condition is meralgia paresthetica. Meralgia paresthetica is nothing but entrapment of the lateral femoral cutaneous nerve just below the inguinal ligament. You know the risk factors: a tight belt line, an obese patient, somebody who has a female who tries to tie a tight in skirt. All these patients do develop a meralgia paresthetica. So how do you diagnose meralgia paresthetica? Either it's a diagnosis of exclusion. Again, a lot of differential diagnoses are there. You should rule out a facetal referred pain. You should also rule out if there is anything like a radiculopathy, or sometimes a peripheral neuropathy, or post-herpes status. So where do you look for a lateral femoral cutaneous nerve? Is just above. This is the anterior superior iliac spine, and trying to image the sartorius. That's the inverted triangle sartorius. You could see there is a fat-filled tunnel, fat-filled flat tunnel, where you have the lateral and the anterior branches of the lateral femoral cutaneous nerve. Doing an in-plane needling, getting into the flat-filled flat tunnel, giving in a perineural 5% dextrose injection, trying to release it. There is a little bigger nerve there. If it is pathological, it will be definitely enlarged. So you'd see a bigger nerve as you try to hydro-inject around the lateral femoral cutaneous nerve. Again, it has to be done at least 2 to 3 sittings for consistent results in pain relief. And see here, do not use steroids for this injection. Always use 5% dextrose. For beginners, it might look a little bit meaningless to inject 5% dextrose always. but it is one of the most efficient ones for treating entrapment syndromes. This is one important image which I wanted to share. A common peroneal nerve at the head of the fibula. This is the head of the fibula, and you could see there is a common peroneal nerve, and there is a small cystic structure there. That cystic structure turned out to be a ganglion. This was shared by one of my friends, Dr. Sadashivan. Just sharing the video there. This is the nerve. It's the head of the fibula. You could see there is a small cyst. These are very rare pictures. You do not get it regularly. This is the common peroneal nerve ganglion. Okay, I think I have done a very, very short lecture trying to make it comfortable for everyone to learn, so that the idea was to search for these entrapment syndromes rather than teaching you the entire detail of these entrapment syndromes. Thank you so much. Do register for our conference. It's one of those landmark conferences which you are going to attend. Thank you so much.
Thank you, Madhan. It's an excellent short presentation, but it's a very excellent presentation with a lot of take-home messages, not only related to the intervention, but also the clinical findings and the correct diagnosis and selecting the patient for the interventions. I have some queries before taking up from the this thing. Is there any role of pulsed radio frequency in nerve entrapment syndromes?
See, pulsed radio frequency is something. See, pathologically, these entrapment syndromes are by mechanical factors. Mechanical factors in the sense, there could be a small ligament, there could be an interfacial plane, there could be something related to a trauma, maybe intra or an extra neural cyst, or sometimes a pathology or post-traumatic pathology. All these are reasons. To relieve the pain, you can actually suggest a pulsed radio frequency. Particularly what you are asking is probably a lateral femoral cutaneous nerve, LFCN. But I would say doing a LFCN injection means that you are going to release it. That will be the best choice rather than actually doing a pulsed RF, because it is a mixed nerve. Sorry, it's a sensory nerve rather. Okay, you are going to give a pulsed RF and you are going to create probably numbness for a short period of time. Instead, you can just do a release with 5% dextrose. Maybe every 3 months also you can do it. And once they do a lifestyle modification, definitely they will get better. But current amount of evidence points towards only 5% dextrose rather than 5% dextrose, better than steroid, better than pulsed RF.
Okay, you use 10 ml volume for every entrapment syndromes, or is it a dose of variation?
No. Actually, see, 10 ml is the recommended and suggested dose for any carpal tunnels. Okay. And if it is for different nerves, actually, I personally believe that all these entrapment syndromes should be injected on the long axis perineurally. But many times we don't really get the nerves actually. So around 3 to 4 ml is much sufficient for smaller nerves. For a bigger nerve like median nerve into the carpal tunnel, you require 10 ml.
Okay. There are a lot of questions related to how to prepare 5% dextrose. Do you use that 5% dextrose, 500 ml volume, that same thing, or you prepare 5% dextrose?
I use the same sterile 5% dextrose which is available in the market.
Okay, 500 ml volume, that bottle only you use.
And use it for only one patient. Do not keep it for the next day. These are rules which I think like everybody has to follow.
Okay. Related to needling, you are emphasizing again and again over the 26 gauge 1.5 inch needle. Is there any specific reason for that?
See, thing is like infiltration of local anesthetic at the start of the procedure. I normally try to use only 0.5, 0.2 ml of local anesthetic just to enter. That's all. So if I really want to do it with a slightly bigger needle, then probably more local anesthetic will be given, and I would lose the specificity of the procedure. See, the procedure must be to give a perineural dextrose, it is not perineural local anesthetic. So to give dextrose, I don't really want local anesthetic. Local anesthetic is only for the skin. That is why I choose a little rather non-painful needle, that is 26 gauge needle, nothing more. Really speaking, means like if you really have had a look at the retinaculum in a cadaver or even a surgical procedure, even a surgeon is doing, you just have a look. It's a slightly bigger retinaculum, which we are looking at normally. And your 26 gauge needle or 18 gauge needle rather doesn't really like make any difference, because like your needle fenestration is going to go through one single point of entry. It is not really any release or anything. Whatever we are seeing, the effect of this particular carpal tunnel injection is by 5% dextrose rather than your needle. So I personally believe that your needle fenestration is just to satisfy yourself rather than actually giving any kind of relief to the patient by relief of mechanical, by way of mechanical relief. Definitely, your 5% dextrose is the one which is going to do the job than the needle.
Okay. Just asking about some people asking about whether you use 26 1.5 inch needle.
1.5. See, with that 1.5 inch needle, the same needle can be used for local anesthetic and entry into the carpal tunnel also.
But you don't inject perineural local anesthetic, right? You inject
no,
only
I don't inject perineural local anesthetic at all. No, never.
Okay. Okay. So you use only 5% dextrose.
Only 5% dextrose. See, there are times, like where you need to see something like, I think Guru also would agree that if you are going to go for a facet joint injection, I think the volume is going to be hardly 1 ml. Okay, I'm not going to inject some 2-3 ml where you lose the specificity of the procedure. Basically, what I want is once I inject only 5% dextrose, only perineural, nothing more.
Okay, so after the procedure, post procedure, what type of instructions you want to give? You want to take the patient with medication?
Post procedure, as always. Like, there are a couple of very important take home points which I want to tell. If you are going to do a radial side needling, you will always tend to hit the FCR tendon, that is flexor carpi radialis tendon. So you will always have a post procedure soreness of the thumb. So the patient will always try to have a difficulty in moving the thumb. So give an ice pack, definitely yes. So for which I always try to do only an ulnar side needling. Only problem is you might actually touch the ulnar artery and the nerve, which can easily avoid. Try to do a pisiform down maneuver so that you can enter into the carpal tunnel easily. So always try to do an ulnar side needling, ice pack and paracetamol for 2 to 3 days, and nothing more is required. And you need to educate your patient that this is not for pain relief. This is for remodeling your median nerve. So remodeling your median nerve means that it takes at least 6 weeks for remodeling. So I will always suggest go for 2 to 3 injections, depending on the type of relief the patient presents with. Patients who have numbness always take a lot of time. Patients who have motor weakness, they take a lot of time. That is why I say patients with motor weakness, patients with severe form of carpal tunnel syndrome, they always qualify for surgery. Patients with mild to moderate, without any motor weakness, they qualify for the intervention. So always try to see not all your carpal tunnel patients should be subjected to intervention. Interventions are limited for mild to moderate patients. Severe patients should always be subjected to surgery.
Is there any complications or precautions we have to take for using 5% dextrose? Like
no, there is nothing actually. We are going to give it only in the local environment. So the local environment injection of 5% dextrose is going to actually benefit. Even if it is a diabetic, you really need not worry. So it is going to be a local injection of 5% dextrose. So it does not have any systemic effects at all.
Is there any role for diagnostic block with local anesthetic in nerve entrapment syndromes?
I feel all these blocks are to be labeled as diagnostic cum therapeutic blocks.
Okay.
So essentially, I feel like by giving a 5% dextrose injection, you really don't, means like you may not get the local anesthetic effect you want, but definitely like you will get a long term. See, for any diagnostic block, definitely you'll wait for 24 hours if it is a local anesthetic. Definitely the patient is going to say pain relief is there. Once you give it, they will have pain relief immediately. Suppose if it is a carpal tunnel or a cubital tunnel, immediately there will be some pain relief. We really tend to mistake that actually. It is not in no way specific actually. So better give a 5% dextrose injection. Take it as a diagnostic and therapeutic block. I have seen plenty of even very senior pain physicians really like they are not very comfortable with 5% dextrose because we are not able to gauge the success of the procedure because patient tends to complain about pain even after 4 weeks. Really, I'm telling you, carpal tunnels definitely have a huge role to play. That the 5% dextrose has got a huge role to play. You need to see the you can see the size of the nerve. You can look at the long axis of the nerve, try to see if there is a reduction in the compression. And more importantly, you can see small fascicles which are starting to appear within the nerve. That means that you are, those fascicles are indicative that the nerve is actually getting into normal.
Yeah. Say what will be the how frequency, like how long you will inject it, how many injections in, what will be the this thing?
Typically you need to have 2 things before injection. One is a diagnostic ultrasound. Before that, you need to have a nerve conduction study. So both of which actually are equal. They go hand in hand. You cannot just say that I don't have a nerve conduction study. I've got a huge nerve. I want to inject. No. There are a lot of times a big nerve by ultrasound study. I have sent for nerve conduction study. It came out to be non-carpal tunnel syndrome, demyelinating, sometimes like a peripheral neuropathy. All that actually has come up. Never do without these 2. Both ultrasound and nerve conduction study, both are required. Number 2, day 1 of the procedure, you always educate these patients that they are not getting a pain intervention done. They are getting a remodeling intervention done, and it has to be done every 4 weeks for 3 sittings. And if 3 sittings the patient is not getting all right, then probably you will have to relook at the diagnosis and relook at the choice of treatment. Probably he or she may require surgery.
So you want to inject every week?
Every 4 weeks.
Every 4 weeks into 3 times.
3 sittings.
Same protocol.
3 sittings. Okay. 3 sittings.
The same thing for neuralgia also? Or
yeah, everything. Every entrapment syndrome, I'll tell you, no entrapment syndrome can be treated with 1 injection of 5% dextrose. The entrapment syndrome means there is a mechanical compression. That mechanical compression should be relieved only with repeated injections of 5% dextrose. You can do it every week also, not a problem. The protocol is to inject every 4 weeks for 3 sittings.
Okay. Is there any scientific reason for that prolongation, that 4 weeks duration, or should we wait after a single injection? Is there any scientific?
No, actually, there are mild cases which respond to even a single injection. Not a problem actually, but even though there are some histological evidences to say that there is an improvement of your compression, definitely like it is only by clinical methods which they have found out. I think you must have read Dr. Stanley Lamb's articles. I think some 2-3 articles he has a lot of meta-analysis also are coming up, that it is only these 3 sittings which are essential, and the duration apart, actually you should give at least a 4 weeks duration in between.
What type of anti-neuropathic medications you will prefer for nerve entrapment syndrome patients? Like you prefer duloxetine or?
If you really ask me, I don't prefer any anti-neuropathic agents.
Okay. So you rely only on the physical therapy plus.
See, means like I think we cut short that discussion. After the procedure, we need to give paracetamol, ice packs, and probably like for the next 4 weeks, use the splint. Continue with the splint actually.
Okay.
Continue with the night splints.
When will you select Botox for your therapy?
See, Botox is something which I have not used for carpal tunnel, but there are literature of say around 18 patients have been done, and all these patients, Botox has been used by injecting into the muscle. It is rather not injected into the tendon. So the muscle actually gets relaxed. There is less tension on these tendons by which your carpal tunnel syndrome is getting relieved. That's a mechanism which has been given actually, but I don't have any personal experience. Around 50 units in distributed aliquots. It's given into the muscle.
Okay. Thanks, Madhan. Thank you. A very nice discussion. And sir, Edward sir, is there any other question from your side?
Move on to the next session.
Oh, okay.
Rajesh sir, can I add something on pulse star?
Yeah, Guru.
Yeah, Guru, please.
Yeah, sir, pulse star, yes, obviously hydrodissection, those things are very important for entrapment. Yes, you can try pulse star because still the debate is there whether pulse star works or not. Even for other conditions like DRG, whether it's going to work or not. Again, the thing is, it is not going to harm. Usually pulse star don't produce any numbness because the temperature is set at 42.
Yeah,
it's don't do harm. But I had got good results for shoulder in doing suprascapular. Now I tried because I don't have any option. I tried a steroid injection. Most of the time I do steroid injections. Now people are doing their hydrodistension. So now I always try, but nothing works. Then I think I try pulse star.
My worry is only one thing, Dr. Guru. Actually, it is basically we are not doing a nerve related injection. We are trying to release a adhesion or sometimes like something mechanical which we are trying to do. I think pulse star does not do that.
Yeah, I understood, sir. You did everything. You did hydrodistension. Still, the patient is
You can, for relief of pain, definitely yes.
Yeah. Yes. So it's if you have tried everything and the patient is still symptomatic, I think pulse star is not going to harm the patient. So you can try. I had tried in shoulders, but it has given good results so far. But it never gives results every time. It's nothing like you try, you will get the relief. No, you are actually dissection is trying to take up the pathology, and this is just a palliative procedure. The patient is suffering. Okay, at least try something which is going to work. I think pulse star can be tried, but only as a last option.
It is worth trying, and even if it doesn't work, it doesn't matter actually.
Yeah, it doesn't harm.
Yeah, it doesn't harm too.
I have done in Meralgia parasitica where I do 5% dextrose hydrodistension followed by that pulse star as a neuromodulation. Sometimes it works actually. 1 or 2 patients they got some good pain relief. That's why I asked.
I think if Dr. Madhan is doing, I think he can keep it as a control, combining hydrodissection with pulse star. You make it as a control. You do 10 studies, 10. I think you are the best person to do those studies because we are not seeing that much common.
And I'll tell you, this tunnel actually, like LFCN, which we are trying to see is much less than the belt line actually, much lower. Essentially, the hydrodissection, the needle should be from caudal to cranial so that you give in your 5% dextrose along the course of the nerve on its long axis. That is actually coming up. So what we are doing is a short axis injection. The long axis injection, caudal to cranial, that's going to be the next way of intervention probably.
Madhan, before closing, there is one interesting question. Like, where else you use 5% dextrose in any bursa injections, subdeltoid, anserin?
See, I will tell you actually. Like these are very two specific questions which has been asked. See, pes anserinus, I think like lot of people have been using steroids. I think I was using quite a lot of steroids with good success. If it was a bursitis, definitely yes, I will use only a steroid even now. But very clearly, what is pes anserinus bursitis is because there is a tendinopathy of the pes anserinus complex. It's a tendon. It's a tendon which has become weak. By injecting steroids, we are making it weaker. That's the reason. If you have significant amount of fluid, probably you can aspirate it and just leave it as such. Or maybe an NSAIDs course. Or you can aspirate it, put in 5% dextrose, or it must be injected PRP, something which is actually something which is emerging. Second thing is for subacromial bursa. Subacromial bursa, again, a patient who has got a tendinopathy deserves 5% dextrose than a steroid. If the patient has a tear, definitely, as you know, PRP. If the patient has got only a tendinopathy, I think 5% dextrose is much more than sufficient.
Okay. Thank you, Madhan. Thank you. Shall we move on to the next one? The next presentation is by Dr. Vissnukumar. He is from Hosur, Sekara Hospital, Hosur, consultant pain physician from there. And he is going to enlighten us with his video presentation on Splanchnic neurolysis, how he does it, and it is for upper abdominal malignancies. Over to you, Dr. Vishnu.
Good morning, sir.
Yeah, you can start.
Sir, am I audible, sir?
Yeah, you are audible. Your screen is visible. The presentation screen is visible.
Fine, sir. Thank you, Edward, sir. Thank you, Rajesh, sir, for this opportunity. And good morning, everyone, all attendees, especially the postgraduate students. I purposefully wanted to put this topic for two reasons. There are two exam questions related to this topic. I'll be teaching the basics of anatomy and how the procedure is done, and then the WHO pain ladder pattern. And second thing, once I end my slide, I just wanted to know, I wanted to explain you what is pain medicine, what all we do as an pain physician, and what are all the career options that is available after your post-graduation study. So let us move to the topic per se. I have not made it as a complete video session because if I put it as a video, definitely you youngsters will not understand. So I have explained each and every step as a photographic images, and in the end I'll be sharing you all the entire video so that it will be very helpful for you to understand. So first step, if you see, this is the most important exam question. What do you mean by the WHO step ladder pattern? See, any patient who comes with the chronic pain means pain which is persisting more than 3 months. So initially, you'll be calculating a score, whether you do an NRS score or VAS score or something. NRS score is the simple thing, numerical rating scale. So it has a scale from 0 to 10. So 0 means you are suffering from no pain. 10 means you are suffering from a very severe pain. That is, you are amputating a finger without giving any anesthesia. So if the patient is saying that he is having an NRS score of 0 to 3, then you can start with non-opioid analgesics and NSAIDs. Okay, non-opioid analgesics and NSAIDs. 1 minute. So you can start with non-opioid analgesics and NSAIDs like paracetamol, diclofenac and everything. But if the patient says that if the pain score is between 4 to 6, then you have to start with weak opioids like tramadol, tapentadol and all these things. But still, if the patient is telling you, sir, I am having a pain with an NRS score of 7 to 9 or 10, then you have to start off with opioids like morphine, buprenorphine, pethidine, and all these things. So if the pain is not relieved with all those things, then we have a step 4, which includes interventions, nerve blocks, epidurals, patient control analgesia pumps, neurolytic block therapy, and spinal stimulators. So keeping this WHO pain ladder as a basic, we are going to step into this. Okay, so this is a very important exam question. You have to draw this diagram and you have to mark it properly. So just by seeing the diagram, the examiner will think that, okay, you have known the concept and you can score the marks. It is basically an important 5-mark question. And coming to the topic per se, this Splanchnic nerve block can provide a pain relief of chronic visceral upper abdominal pain. Either it can be malignant or non-malignant. Malignant conditions like CA gallbladder, CA pancreas, CA stomach. Okay, and non-malignant condition, mostly I'll be doing chronic pancreatitis, atrophic pancreatitis. I'm doing this splanchnic nerve neurolysis. And this splanchnic nerves transmit the majority of nociceptive information from the viscera. Okay, so this is another important question. The autonomic nervous system, that is the sympathetic nervous supply of the organs, that we'll be seeing in the next slide. And this splanchnic nerve is formed by the greater, lesser and least splanchnic nerves. The greater is from the T5 to T9 segments, lesser is from the T9 to T11 segments, and the least is from T12 segments respectively from the spinal cord. So if you see, Okay, this is the functional anatomy. Here you can see sympathetic chain, which contains of sympathetic ganglia, sympathetic trunk, sympathetic ganglia, and this is called as the sympathetic trunk, which is present on the either side of the vertebral body. Okay, either side of the spinal column, and from here the sympathetic nerves reach the various organs like thoracic viscera, abdominal viscera. And this sympathetic chain is present in the entire spinal cord. It is present from the cervical region and ends at the level of the coccyx, where they unite to form the ganglion impar. And now, this is the very important slide, sympathetic innervation of the viscera. See, sympathetic nervous system starts from T1 to L2. So sympathetic innervation is from the thoracolumbar outflow, whereas the parasympathetic innervation is from the craniosacral outflow. In cranial region, we have oculomotor nerve, 3rd nerve, facial nerve, 7th nerve, glossopharyngeal nerve, 9th nerve, vagus nerve, 10th nerve, and S2 and S3 sacral nerves. These 6 nerves form the parasympathetic outflow, whereas the sympathetic outflow is from the thoracolumbar region. That is a very important MCQ question, because the sympathetic chains will come from here, and this sympathetic chain is going to go up into the cervical sympathetic chain, and it is going to supply the organs of the head and neck. And you see, the entire body is supplied by the sympathetic system. Okay, see, the upper limb has a sympathetic system innervation of T1 to T3. Okay, whereas the thoracic viscera has a sympathetic innervation from T1 to T5. That's why the sympathetically mediated pain is always non-segmental. It is ill-defined. A patient is coming with the MI, myocardial infarction. He is not localing his pain to the chest. Of course, he does, because of the inflammation of the pericardium. And he always says that, sir, my pain is radiating to the trapezius muscle. It is going to the upper limb because of this. The thoracic visceral is being innervated from T1 to T5. The upper limb is also innervated from T1 to T3. And of course, it is going to the, from these things, it is going to radiate to the upper limbs also. Now, here, coming to the topic per se, we see that this T5 to T9, they unite to form a greater splanchnic nerve, and T9, T12, they form lesser splanchnic nerve. They all join together to form the celiac ganglion, and from the celiac ganglion, the postganglionic fibers go to the respective abdominal viscera and they do innervation. So we have 2 nerves. The efferent nerve is efferent nerve of the upper abdominal viscera innervation is from the T5 to T12. That is the splanchnic nerve. From T5 to T12, they go to the celiac ganglion. Postganglionic fibers supply the upper abdominal viscera. Now, the afferent nociceptive fibers always travel to the celiac ganglion, and they in turn merge into the splanchnic plexus, and from here they terminate in the dorsal root. And once they come to the dorsal root, from the posterior spinothalamic tract, the second order neuron goes to the thalamus, and from here the third order neuron goes to the limbic system and the somatosensory cortex. This is how the pain is perceived. So whenever there is an inflammation, whenever there is an alteration in the structure, or whenever there is a mechanical deformity, the patients will be the somatosensory cortex will be stimulated. Along with that, the limbic system will be stimulated. That's why when you see a patient with pancreatitis, he will not be happy because the limbic system is stimulated. That will control the emotion. You can see them in the dull face, keeping their hands touching to the stomach. So this is the main thing, because their limbic system is stimulated. Okay, now to the topic per se. Now you can see from the T5 to, this is the parasagittal anatomy. So this is the splanchnic nerve, greater splanchnic nerve from T5, T6, T7, T8. And T9, they unite to form the greater splanchnic nerve. T10 and T11, they form the lesser, and T12, they form the least. Okay, and now all these 3 things are P-ganglionic to celiac ganglion. Okay, now these 3 splanchnic nerves pierce the crust of the diaphragm and they coalesce into the celiac ganglion. Now, if you see this splanchnic nerve, why we are targeting here? Because this splanchnic nerve, you see, the location of this splanchnic nerve is well defined. First point. Medially, you have a vertebral body. Laterally, you have a pleura. Okay, and caudally you have the crus of the diaphragm. And when they form the ganglion, okay, this ganglion is front of the aorta. Okay, now when we see the anterior view, see here, this is the anterior, this is the celiac ganglion, and from the sympathetic chain you have got the greater, lesser, and least. Okay, so celiac ganglion can vary from 2 to 5 in number in front of the aorta. Okay, and see here, they have got the sympathetic afferent and efferent fibers, and they have also got the parasympathetic fibers. So what is the role of the sympathetic fibers? The sympathetic fibers is going to contract the sphincters, relax the smooth muscle, and it is going to inhibit the secretion. The sympathetic fibers are going to carry the nociceptive information from the upper abdominal viscera. Okay, whereas the parasympathetic fibers, mainly from the anterior and the posterior vagal trunk through their branch of vagus, especially the posterior vagal trunk and the anterior vagal trunk, directly innervates the viscera, which helps in the viscera mobility and the secretions. Okay, now the main thing, previously, many years before, what they happened was whenever the patient presented with any upper abdominal malignancy or pancreatitis, they were telling give celiac plexus block, celiac plexus block. Now celiac plexus block is literally obsolete. See why? The problem is you are bringing a needle and you are injecting local anesthesia and alcohol. Okay, but the amount of drug that you are giving, you are not sure whether your drug is reaching the ganglion 100% effectively, so that you can get a 100% good result. So we are giving a drug in an assumption that, okay, it is going to spread here. But now, as you see in this diagram here, the location of this splanchnic nerve, everything is prefixed. So you bring your needle here at the level of T11, you do a radiofrequency ablation, you are targeting the nerve, you are burning the nerve, so that the duration of pain relief is excellent. And I am doing a comparative analysis. Till now, there is no comparative analysis, just few paper presentations are there comparing celiac plexus and the splanchnic nerve. And I have done around 30 cases of this, and I am still writing on this, the comparative evaluation of both the splanchnic nerve and the celiac plexus neurolysis. And I'm just going to discuss what I have done to my patient today. Okay, so I hope you understand this diagram. So when you want to do a celiac plexus, you bring a needle here. You directly bring from the needle here, you keep it in and you're not exactly destroying the nerve. You're not exactly destroying the plexus. Basically, you're just giving a drug. You're assuming that, okay, it is going to spread here and it is going to block in either direction. So whatsoever it is, either you do under fluoroscopic guidance, whether you do under endoscopic guidance. I have done CT robotic guided celiac plexus block also. But even then, the results of splanchnic neurolysis are extremely far greater. Okay, now how I'm going to do a procedure. Okay, so let us go step by step. First, I'll be taking an X-ray PA view. So posterior anterior view. So this is the 12th rib, because after this, the vertebra do not contain any rib. So this is the 12th rib and this is the 11th rib. The 11th vertebra and 12th vertebra, thoracic vertebra are the area of interest. So I'm going to mark this vertebra. Okay, so this is how I keep my patient. I'll keep my patient lie in the prone position, and this is the fluoroscopic image. So you'll be taking a PA view. And this is how the patient has been placed in the supine position. Okay. And this is the spine model. First thing is that you have to take an AP view. And this is the red one is the L1 vertebra. This is thoracic T12 vertebra, and this is the T11 vertebra. T11 vertebra is the point of interest. Whenever you do celiac plexus, the L1 vertebra is the point of interest. Okay. Now, whenever you are taking PA view, so as we discussed in the diagram, the sympathetic ganglia lies here, and this is the sympathetic trunk. The sympathetic trunk is nothing but the axon, and here you have got a sympathetic ganglia, and again here this is the sympathetic trunk, and this is the sympathetic ganglia. Both the sympathetic ganglia and sympathetic trunk is called as the sympathetic chain, which is present on the either side of the vertebral body. Okay, and you take a lateral position, and in this lateral position, your sympathetic chain lies this way. Okay, so you have to keep this location of the sympathetic chain very important. Okay, so now you take a lateral view, and that is how you get the previous image. And here you can see the sympathetic chain, how it has been aligned here. Now, in the lateral view, if you see, so this is the T11 vertebra and this is the T12 vertebra. From T5 to T9, the greater splanchnic nerve is coming like this. From the posterior to anterior, and the lesser splanchnic nerve from T10 and T11, they are joining, and it is at the level of the T11 vertebra, and it is fixed. Okay, and now the T12 least splanchnic nerve is coming here. Okay, now what I'm going to do is I'm just going to do a radio frequency ablation. So I'll tell you what is radio frequency ablation later. So by this image, you can come to a logic that once you keep your needle here and once you burn the tissues, obviously you can target both these nerves. And then I give an alcohol and it is going to cover this nerve also. And the majority of the neural tissue can be destroyed, so that the duration of pain relief will be more than 1 year. More than one. This is the simple concept. But when you do a celiac plexus, I have seen patients coming to me after 1 month or 2 months coming, sir, again the pain is coming. Because you are not targeting the nerves. See, all these three nerves are joined from the celiac ganglion and celiac plexus later. Okay, now this is the orientation. Okay, now if you see all these sympathetic chain, from here the nerves are going from the lateral to median portion. See, whenever you do an X-ray, you are going to do only a 2-dimensional image. You are not going to see a 3-dimensional image. This is the 3-dimensional orientation of the nerves. The green one is the greater splanchnic. So this violet one is the lesser, and another one is the least. This is the thoracic T11 vertebra, and this is the T12 vertebra, and this is the L1 vertebra. See, L1 vertebra, they do not have ribs. T12 vertebra, they do have ribs. Now, I hope you have understood the background of this one. Let us start with the procedure. Let me do my case. This is a 50-year male. It's a case of end-stage carcinoma pancreas. No signs and symptoms suggestive of intestinal obstruction, no evidence of ascites. There is no diarrhea, no hemodynamic instability. The RFT is normal. Bleeding profile is normal. And CT abdomen. This is the very important point I wanted to say. CT abdomen, mating of celiac plexus with adjacent solid and hollow viscera. So what happens whenever there is an atrophic pancreatitis or whenever there is any carcinoma, the surrounding structures are completely destroyed. So the normal anatomy of the celiac plexus itself is destroyed. Okay, and there is a compression. So when you are doing a celiac plexus, you cannot say that confirmly that, okay, I'm going to give this drug, it is going to destroy my intestine. No, you cannot say that. And the literature is coming now. So you have to do a splanchnic plexus block to get an effective relief. And now the patient is on tablet morphine 120 milligram per day. And he's on anti-neuropathics, tablet pregabalin. And he came to me and he was telling me, he was literally touching my foot. Sir, please help me some more. Even if it takes like 5 minutes of delay while taking morphine, I'm having severe pain. It's like someone taking the knife and directly putting it in my stomach. So he just came to me and he told me, sir, please help me out. Otherwise, if you cannot relieve my pain, give me some medicine and make me die. This is what he told me. Literally, this is what he told me, and he was begging me. So he was having, because of this pregabalin, he was having excessive sedation, and because of this tablet morphine, despite taking Crimafin plus, he himself used to keep enema every day just to pass motion. All these were the side effects of opioids. Okay, and now come here. Okay, now this patient has been planned for Splanchnic neurolysis, combined radiofrequency and alcohol ablation. So pre of preparation, vitals monitoring, BP, SpO2, ECG was being done. Preloading 500 ml of intravenous fluid NS was given, and I have given ceftriaxone 1 gram. Okay, and patient position, I kept in a prone position with pillow beneath the hip so that his abdomen is entirely free. And then I just wanted to ensure that I'm not compressing his IVC also. Okay, so these are the material used. I used 25 gauge, 15 centimeter RF needle with 10 millimeter active tip. I'll tell you what is RF now. And I used some extension tubings, syringes, local, dexamethasone, and contrast. Okay, this is very important tip. Whenever I use, you can see my needle. See here, the tip of my needle is bent. I just wanted to purposefully show, 1 minute. Yeah, see, the tip of my needle is bent. Okay, so why I'm bending this needle? Because that is going to help in my navigation. The tip usually directs my needles. So if I'm keeping my tip in this direction above, as I push, my needle will go up. You can see, as I push inside the body, my needle will go up. And as I come down, it will come up. So the direction, this will help me to navigate where I should go. Okay, and the procedure site is clean and draped. Now, starting off the procedure, first I'm doing it on the left side. I'm going to mark the superior lateral portion of the T12 vertebral body. I just want to make sure that my entry portion is above the ribs. See, now this is the T11 vertebral body, and I want to make sure I'm marking my point here so that I just wanted to go above the ribs. So I will enter my needle in this direction. I hope you can see this one. I'll enter my needle in this direction. So basically, I want to rotate my spinal cord. This is just a spine model. So I'm just rotating a spinal cord like 15 degree so that I can see the rib and make sure that my needle is crossing in this manner. Okay. Now, first I'll be taking an ipsilateral oblique view of 10 to 15 degree. So once I take, I can see a thickened line, which is nothing but the pleura. Now I have inserted my needle in the superior lateral portion of the T11 vertebra. Okay. And now I take the lateral view. Now, why I just want to go above the rib? Because here you can see, this is the foramen. Okay, this is the foramen. See, through the foramen, the uppermost portion has the nerve root. So I am ensuring that if I go above the rib, I'll always go to the lower portion of the foramen so that I will not injure my spinal nerve. So after this, I'm very pretty much sure that my needle is in a perfect direction. And now see, I'm showing in my image model. See here, you have got the ribs. Just above the rib, I'm just going, and this is the nerve root, and my needle is exactly below the nerve root. Okay. And now I want to make sure that my needle is grazing the vertebral body on its lateral surface in the AP view. Can you see, this is the T11. So this is where the greater and lesser splanchnic nerves are present. And now I'm just subsequent lateral view images. I'm just inserting my needle slowly inside. I'm seeing whether my needle is going in the right direction. And now the final needle position in the lateral view. The final needle position is always at the junction of anterior 1/3 and the posterior 2/3. Okay. Now keep this image in your mind and then compare the previous image where I showed you the nerves. Let us see that again. Okay, now this is my final image. Can you see in this spine model? My needle is grazing over the vertebral body. The vertebral body acts as a very important landmark here. It is just grazing over the vertebral body where I can be, where the nerves are there. Okay, so this is at the junction of anterior 1/3 and the posterior 2/3. Okay, and final needle position in the AP view also you can see that my needle is grazing the vertebral body. Okay, so similarly, I am doing it in the opposite side as well. So you can see both the needles coming here, and finally, both the needles are exactly in the anterior 1/3 and posterior 2/3 junction. And this is the final image of my needle. Okay, now what happens? I am just doing a radio frequency ablation. So in simple terms, what is radio frequency ablation? Okay, I'm just going to show you this. See, radio frequency is nothing but this is the needle where you give electricity. The electricity is going to produce radio frequency field. And this needle tip is placed near the nerve. And this radio frequency is going to cause oscillation of the ions. And this oscillation of the ions is going to produce heat energy. And that heat is going to destroy your nerve. This process is called as ionic heating. So it does not heat the probe directly. The ionic oscillation is going to heat the probe and it is ultimately going to destroy the nerve. So for this radio frequency to happen, what you have to do, you have to ensure that your needle, see here, as you see in this image now, your radio frequency needle tip should be parallel to the nerve. This is the most important prerequisite, and as it generates the heat, it will destroy the tissue, nerve tissue, which is surrounding to it. Okay. So, and these are some of the parameters. So the resistance is always less than 200 ohms. As you can see in this image, here you can see my resistance is around 155 or something. And you do a sensory stimulation. So sensory stimulation and motor stimulation, why you do? So because before doing any ablation here, your main target is destroying the sympathetic innervation. Okay, destroying the sympathetic inner. At any cost, you should not destroy the somatic nerve fibers. Do you understand? So whenever you do a motor stimulation, you should not see flickering of intercostal muscles or abdominal muscles. Okay, and whenever you do a sensory stimulation, the patient will say, sir, I'm having similar pain to that I perceived before. And there should be no pain over the chest, indicating that you are not stimulating the intercostal muscles. Okay. So now, before doing a lesioning, what I'll do is I'll just give like 1 ml of alcohol. And then a radio frequency is done. So as soon as I give alcohol, you can see my resistance is dropping down from 155 to 116. And then I used to do a double lesion with a temperature of 80 degrees and duration of 90 seconds. Okay. So now you can see, imagine that, wait, let me show you. Yeah. Now you can see my needle is here. Okay, my needle is here. When I am going to do a radio frequency ablation, I am going to destroy both these two nerves. Okay, I'm going to destroy both in the right and left side. Now, but the thing is, if I want to do in the least, if I want to destroy my least splanchnic nerve, again, I have to do the same procedure at the T12 level. But now what I'm doing is, I'm just using 2 needles and I'm combining the radio frequency ablation with the alcohol neurolysis. So when I give alcohol, what happens? The drug is going to spread from here till here, and it is going to destroy the many more segments of the splanchnic nerve. So this is the rationale behind. And now, as you see, the nerves are coming from posterior to anterior, and here the nerves are coming from lateral to medial. Can you see? It is from lateral to medial. So this is, you have to imagine it as a 3-dimensional image. Okay. So now you can see, once I give my dye spread here, the dye spread in the AP view, it is from lateral to medial. I always give 1 ml of dye. So if I give an alcohol solution of like 5 ml, then I guess it is going to spread more. So there was a satisfactory dye spread in AP view. Again, in lateral view, you know that my nerves are here, here, okay, and then lesser splanchnic nerve is here. So I do a radiofrequency ablation here, and then my dye spread, can you see here? This is the dye spread here, and now I am going to give alcohol. So then this is 1 ml of dye, and if I'm going to give 5 ml of alcohol, I am in an assumption that, okay, it is going to destroy my least splanchnic nerve also. So after I get a successful dye spread in AP and in lateral view, what I'm going to do, so I'll take, see, this is the satisfactory dye spread in the bilateral. In the AP view, you can see this dye is going from lateral to medial. So it means that all my nerves are being covered. Okay. So I used to give 5 ml of 5 ml of 100% alcohol. Now, what is the mechanism of alcohol for neurolysis? Alcohol is going to cause protein denaturation, protein coagulation, and is going to destroy the nerve. And thereby, what happens? So the nerves will get destroyed, and the transmission of nociceptive impulses will be abolished. So post-procedure precautions, what I do? I keep the patient prone for 30 minutes and I give NS RL 500 ml again, and I do BP monitoring. And in the procedure, I used to give paracetamol 1 gram and injection diclofenac 75 mg IV, and is shifted to ward after 2 hours of observation in the recovery room. Okay. The patient was discharged after 1 day of observation. I just gave an analgesic, etoricoxib for 3 days. And then morphine, I reduced drastically for 60 mg per day for 5 days. He was taking 120, and then pregabalin, MSET, and perinom. Okay. And advised to review after 5 days and after 1 month. Okay. So patient status on review after 1 month. So his NRS score was, which was like 10 out of 10 when he came present. Now the NRS score is just 1/10. Just 1/10. Only paracetamol 650 mg on SOS basis, which was like 10 out of 10 when he came. He told me that only paracetamol 650 mg on SOS basis. Which was, so this is something a very good, what to say. This is what the happiness and the sacrifice that you have done and the procedure that you have done. This is what you get in return. And this is the beauty of this pain medicine. Okay. So a complication of the procedure, if you are not well versed with the procedure, and if you are not if you're not thorough in identifying the pleura, if you cannot make out a pleura, definitely there is a chances of pneumothorax. And then you're going to do a sympathetic blockade. So definitely you'll be having postural hypotension, for which you have to do an adequate hydration and fistula formation. Always when you give absolute alcohol, you all post procedure, you have to inject 5 ml of air to ensure that you're not letting. You can do 5 ml of air, you can give saline, local anesthesia, whatever it is, and then remove the needle. You should not remove the needle as such, because it can result in formation of fistula. Diarrhea can also be there. Diarrhea will this is because of the sympathetic deactivation, and sometimes if you're not doing the procedure properly, then it can lead to spinal cord ischemia, paraparesis or paraplegia due to the damage of the somatic nerves. Sometimes injury to the artery of the Adam Quicks is also going to cause all these things. Okay, so always stick to the basics. It is very simple. If you follow the basics properly, what I told, the dye spread should always be from lateral to medial in AP view and from anterior to posterior in the lateral view. Okay, so once you do this, keep that in mind. Once you get adequate dye spread and then you perform the procedure, no doubt the patient is going to have a long lasting pain relief. Okay, and then neuritis. Neuritis is also a known complication following these procedures. Mostly, I have just to prevent this neuritis, I'll be giving anti-neuropathic drugs, mainly pregabalin, and after my procedure, I'll be giving a small dose of 2 mg of dexamethasone after radiofrequency ablation. Personally, I have not seen any patients with the neuritis following the splanchnic nerve. I've usually seen while ablating this trigeminal neuralgia cases. So thank you very much. So last 2 minutes, I just wanted to talk regarding what conditions do pain physician treat. So whenever you are dealing with pain medicine. So what is pain medicine? So basically you'll be treating patients with cancer pain, any neuropathic pain. Okay, any neuropathic pain like secondary to entrapment syndrome or trigeminal neuralgia, and you'll be dealing with discogenic pain. Okay, cervical and lumbar radicular pain, sciatic pain, and you'll be dealing with musculoskeletal pain, and you'll be dealing with osteoarthritis. Today morning, I did a case, 70-year-old man, the bilateral severe osteoarthritis of knee. He has a severe LV dysfunction, EF of 25, post PTCA, and he has also got tuberculosis. Okay, and he has got an orthopnea also. So what I kept him in propped up position. I did an radiofrequency ablation of genicular nerves, and now post procedure I made him mobilize. He was not able to walk before. Now, just after 1 hour post procedure, he just walked in. I started this procedure by 6 a.m. in the morning, and morning and 9 o'clock when I came for a review, he's just walking off. So that gives an happiness. Ideally, such candidates has to be posted for TKR, but due to the complications in the post-operative period, he told that, no, sir, I'm not ready to accept this. I'll go for radiofrequency ablation. So he had an excellent thing. Spondyloarthropathy, rheumatoid arthritis, ankylosing spondylitis. Many people do come with shoulder pain or back pain, facetogenic pain. So just with doing some minimally invasive percutaneous spine interventions, they'll be getting a very good relief. Their quality of life can basically see. You cannot limit the joint restriction by giving DMRDs. One patient came to me. He was not able to do flexion extension, and he was not able to do the lateral rotation. What I did was I gave Atlanta occipital joint injection and cervical facet injection. Of course, he was very fine. It was very fine. The quality of life can be improved with by doing these interventions. So these are some of the modalities pain physicians do use. First thing is minimally invasive percutaneous pain and spine interventions. So spine intervention is like a special interest group. I mostly do spine interventions. I do root blocks. And then I do spine endoscopic procedures, endoscopic discectomy. In the cases of sciatica, I do facet. Previously, I was doing facet RF, but now I am just doing facet directly endoscopic rhizotomy. I am regularly using radiofrequency ablation, which I told you. Chemical neurolysis, mostly I'll be using absolute alcohol, 100% alcohol. And I do neuromodulation also. And neuromodulation, I just wanted to say last month there was a program in Ramaya. So where I performed a case of sacral neuromodulation in patients with the chronic pelvic pain. So neuromodulation is a very growing topic. So even you can apply to many painful conditions. And regenerative therapy, I always use PRP for shoulder, hypotonic saline for knee, and in all other cases, I will be using dextrose, where Madhan sir and Salvats like Madhan sir and Gurumoorthi sir explained you today. So thank you very much for your patient listening. So pain medicine is something, one of a beautiful branch. After your anesthesia, you can very well pursue it. And in case of any queries, you can reach me out with to my email or to my WhatsApp. Okay. Thank you very much. Thanks a lot, sir. Thanks a lot.
Thank you, Vishnu. It was a wonderful presentation and nice way of compiling also the things to the juniors. I think because of the time factors, we cannot take the questions right now. I think we can end the session here, sir. Edward, sir, any questions, sir?
Sir, we can end up the session. Thank you very much, Gurumoorthi sir. Thank you, Vishnu.
Thank you.
Presentation. Even beginners can understand and they can do practice for Splanchnic block after seeing your video. Very, very wonderful. Thank you, Vishnu.
Thank you, sir. Thank you,
Thank you, sir. And thank Rajesh sir also for the coordinating today. And also I thank
you, sir. Thank you.
Sir. I also thank Madhan Pandian sir for sparing their valuable time today. I am happy to inform that today's session was relayed in the Pain TV also. More than 500 watched in the Pain TV. I am happy to share with you. And next week we are coming with a critical care update. That I thank the sponsors Akurula and Anaesthesiologist and our media partner Anaesthesia TV. Thank you, one and all. We will meet next week. Thank you, sir.
Thank you. Thank you.
Thank you, sir.